can see right now.
Good evening, everyone. Myself, Dr. Bala, and my
from CMC Vellore.
yeah, here we're presenting a case of 7-month-old baby came with the complaints of disparity of lip and palate since birth. He's a firstborn male child born out of a non-consanguineous marriage, and there's an history of nasal regurgitation present. There is no history of repeated cold and cough. There is no history of ear discharge, and they are feeding with a palladi since there is difficulty in breastfeeding. There are no other associated anomalies, and there is no significant antenatal history. There is no family history of any congenital abnormalities. Immunization is up to date. On general examination, the child is active, playful, vitals are stable, not pale, weight is 7 kilograms, and the systemic examinations are within normal limits. There are no median pits, a mandible seems normal for age, and there's no white forelock of hair, and there are no lip anomalies. On local examination, there's a white complete cleft lip, alveolus, and palate over the right side. On examination of the lip, there's a discontinuity of the white roll, and the cupid bow is obliquely placed and rotated. The philtrum is short on the cleft side, and the vermilion, the medial segment is short, and the lateral is excess. Nasal floor is absent, and there is no Simonet's ball. The nose examination, the tip is deviated to the left side, that is non-cleft side, and the caudal septum deviated to left side, and the columellar height apparently reduced, oblique, and deviated to the left side. The alar base is widened and retrocaudally placed, and there is an alar flare, and there is an absence of alar facial groove over the cleft side. The nostril is horizontal and asymmetric, and that's a cleft of palate from ula, extending from the ula to the alveolus, where the alveolus is well aligned. So coming to the diagnosis, it's a right-sided group 3 complete cleft according to an Nagpur classification with no nose deformity, and there is no any syndromic association. Can we continue with the investigations?
Any panelist would like to ask any questions till now?
Hello.
Yes, sir.
Yeah. So you asked about feeding, and you said the feeding with palladi. You
Yes.
should also ask whether that patient is fed the mother's milk or top feeding, because that is also important as far as the nutrition and weight. So even if they are feeding with the palladi, whether they are feeding the mother's breast milk, expressed milk, or so that has to be also asked, because that is important regarding the nutrition of these kind of kids.
Yes, sir, it's express breast milk policy.
Okay.
Secondly, you mentioned about no obvious physical congenital anomalies, but there are a lot more which
Yes.
may not be visible on clinical examination. So you have
Yes.
to rule these out.
Yes.
Go ahead, I will ask questions later.
RB sir,
Yeah.
would you like to
I can
ask
proceed.
anything now?
No, I can proceed. No.
Okay. You go ahead.
Investigations, we would like to do the routine blood investigations for the anesthesia checkup. We would like to do the ear evaluation for the ENT team. The management, we will first counsel the parents regarding the timeline of the management, which we are going to do in the near future. And we will give them a feeding advices also. And first, we would like to proceed with the cleft repair. We prefer the Villard technique of rotation advancement.
You said ear examination.
Yes, sir.
What specifically are you looking for in a 7-month-old child?
Yes, sir. Since it's like a cleft lip and palate, we are expecting a otitis media, sir. So we would like to rule out the otitis media.
You said there was no history of ear discharge.
Yeah, sir, it's not this.
Then what are you going to, I mean, you're going to, what kind of history you expect for otitis media? And what is the problem? First of all, can you tell me what is the incidence of middle ear problems associated with children of clefts?
Yeah, sir.
Palate?
Yes, sir. Actually, 90 to 95% of the child with the cleft lip and palate, cleft palate will be affected by the otitis media, sir. And about the 45.
No. 80% of cleft children are affected with some middle ear problem.
Yes, sir.
Very few of them actually progress to a full-blown otitis media.
Okay, sir. Yes.
And can you tell me why?
It is because of the abnormal attachment of the tensor villi palatini, which is not able to open the eustachian tube opening, close up the eustachian tube opening, and thereby all the contents which is regurgitated will cause the inflammation of the eustachian tube opening, and it will progressively lead to middle ear effusion.
Okay, so how do you prevent this? How do you prevent it?
Preventing by making the child feeding in an upright position.
This shouldn't matter. It is not related to nasal regurgitation. It's related to repeated attacks of URTI with crusting around the opening of the eustachian tube, and of course the lack of function of the tensor. How do you prevent it?
So prevention regarding the grommets insertion.
Correct. Well done. So if you cannot equalize the pressure from inside, equalize it from outside.
Yes.
Do you have any idea what a grommet is?
Yes, a grommet insertion we used to do in the anterior inferior quadrant of the tympanic membrane. We used to insert, sir. It's a tube which is opening as both the ends, sir.
Yeah, it's basically a dumbbell kind of structure,
yes,
which is pushed inside. So instead of, if you cannot regulate the pressure from within, you regulate the pressure from outside. Of course, there are a lot of problems in Indian children, and they can't go swimming, and they have to be careful about water can enter through the grommet into the ear.
Yes.
Okay, so the incidence of middle ear dysfunction, I'm using the word dysfunction because it can vary from just merely a retracted eardrum to a full-blown otitis media anywhere in this spectrum. So the incidence of middle ear problems is very high, but the incidence of otitis media is definitely not. So I'm sure even Subodh and Mahesh, who have seen humongous volumes, very, very few children actually have a purulent discharge from the ear.
Yes.
That's true.
So basically use the word dysfunction, not otitis media.
Sure, thank you.
Carry on. You said your repair, Millard repair. Are you going to expand on that? Or are you going to? Can you show us for reference the diagram of the cleft, and then Subodh will catch you on what are the problems of Millard in this case?
So like a Millard. What's?
Can you just read the picture of? Can you share the picture again?
Yeah,
Sure.
the close up of the lip.
And before we go on to the repair, I want you to describe the deformity once again, especially the nasal deformity in this child. So
yes.
come to the picture. Yeah, this picture. So say, why is there nasal deformity in this patient?
Because of the abnormal attachment of the orbicularis oris muscle on the medial element.
So which is pulling what? So the orbicularis oris is attached at?
It is on the medial element, it is pulling the columella and the caudal septum towards the non-cleft side. And on the lateral element, it is attaching to the alar base. So it is pulling that apart, making it retropositioned.
So it is pulling the columella towards the normal side, right?
Yes.
So the tip is pointing towards the cleft side.
Yes.
Or towards the right? So why is the flare there? Why is the alar flare, and why is the widening of the nasal sill area?
Because the lower lateral cartilage, the acute angulation between the medial crus and the lateral crus is lost, because the medial and obtuse angle is produced. So the LR rim is flattened.
So what has happened in this case in the process of cleft? I mean, the lip is going apart as well as the alveolus is also going apart.
Yes, sir.
And the base of the LR is situated over the alveolus. So those cases where the alveolus is not cleft, this will not be as wide, right?
Yes.
So the wide cleft of the alveolus along with the collapse, if it is there, it will cause the deformities of the nose, and that is pulling the lower lateral cartilages apart, and that is
Yes.
giving rise to the deformity, right? So to repair the cleft, you should understand the deformity and what is causing it,
Yes.
right? So the location of the LR base on the cleft side, right?
Yes.
So as long as it is there, the deformity will continue to remain there. Now talk about the muscles. Do you see any muscle bulge?
Yes, sir.
Yes,
Muscle
sir.
bulges there is on the lateral segment, sir.
And on the medial segment as
Yes.
well, it is visible. Usually the lateral segment is described as orbicularis bulge, right? So how do you decide I mean, you can do any repair in any case, but what are the things that you keep in mind when you plan a repair in a particular case? For example, in this patient, describe the philtrum.
Yes.
Describe the
Yes.
philtrum.
So the filtral lateral column over the non-cleft side is well defined, sir, and where the filtral lateral column over the cleft side is ill-defined and which is short also. There's a vertical lip deficiency is there over the left side, I mean cleft side, sir.
Yeah. So is that difference between the two filtral ridges is
Yes.
significant, or is a minor like 2-3 millimeter or more like 4-5 millimeters?
It should be more than 2 millimeters.
Yeah,
There's a
it,
difference 2 to 3 millimeters, sir. There's.
yeah, it appears small. So
Yes.
and what is the lip height on the cleft side compared to the lip height on the non-cleft side?
It is reduced, sir.
It is
No,
reduced.
no, it's not just reduced. There is a significant difference between the two.
Yes, sir.
Okay, so before Subodh asks you any more questions, I want you to criticize the rotation advancement procedure. I know it's still the procedure of choice. Most people do it day in, day out, but I want you to criticize the rotation advancement procedure, especially for a case like this, which, as Subodh has pointed out, there is a significant, the lateral element is significantly short vertically. Yes. And as he said, the discrepancy between the filtered columns is also quite marked. And of course, you have the width of the cleft, which is relatively secondary. But now tell me, criticize the Millard repair, or let's not, rotation advancement, criticize the rotation advancement technique.
Since we need a lot of medial drop of the medial element, we need to give a lot of back cuts, sir.
All right. So
we produce a scar at the base, and we might need to reach it till the opposite side normal filtrum. And
no, without doubt, you have to go more than 2/3 of the way across. You have to go beyond the midline also.
Yes.
So first of all, the fact that you are trying to say that a rotation advancement scar mimics the opposite side filtrum is a myth. Because in our Indian patients, at least, most of our filtral columns, Subodh of course can correct me, will end up somewhere in the middle of medial 1/3 of the nostril sill. Okay, very rarely it even comes up to the base of the columella. I'm talking about the normal side. So you are giving a scar on your rotation incision is going well across. So whatever you do with your lateral element is not going to mimic the filtral column on the non-cleft side. Okay, it is going to be that there is no similarity between the two. Number two, as you talked about the rotation, do you think, looking at it from a pure plastic surgery point of view, look at it as a contracture. There is a contracture. What is the principle of release of a contracture?
We should break down the scar from a straight line to a.
No, no, no.
No,
Before
no,
that,
he's asking contracture. Like you release the contracture, recreate the defect, right? So that's
Right.
what he's asking,
so
right?
where do you
Where
release?
through different.
You release at the point of maximum
From
contract.
maximum tension will
Okay,
release.
so you assume now two fixed points. One is the vermilion cutaneous junction, and second is the nose or the columella. These are the two fixed points, and the lip is now contracted between them. Where will you release the contracture? And why is a rotation advancement procedure technically inferior from a pure plastic surgery point of view?
Mukund, can I just add something?
Yes, sir.
So now Mukund is talking about the problem with the contracture release and the tissue deficiency. There has been a small modification which has been done to the Millard,
Yes.
which addresses this problem.
Yes.
Are you aware of that? And most of the people.
Before that,
okay,
you're saying
fine.
about a
Yeah.
second release. You're talking about a second release.
Now there is a small triangle can be added, but
Correct,
let's go systematically.
Yeah.
And,
So the fundamental thing, when you release a contracture, you want to release it at the maximum point of contracture.
Yes.
Where is the contracture released when you do a rotation incision as part of a rotation advancement procedure?
The alar rim.
At the highest point. I mean,
Yes,
at the extreme end point. Therefore, your release of this contracture is never going to be as efficient as something that cuts across the middle of the lip like a typical triangular flap repair.
Yes.
Okay, I'm saying this because when we were in our training, we had Dr. Mahalakshmala and Dr. Pandya. Mahalakshmala used to do only triangular flap, Pandya used to do only rotation advancement. So luckily, we got to do both depending on whose day it was. You need to know both because believe me, if you know a good triangular flap repair, you can get bailed out in problems. So first of all, you're incising, you're making your release incision at the highest point, that is at the nostril sill, which cannot be as efficient as the something incision that is taken in the middle of the contracture band. Second, as you mentioned, as Mahesh also started mentioning, if you take your rotation incision well beyond the normal midline and go 2/3 of the way up to the opposite filter column, and you still don't get horizontalization of the Cupid's bow, what do you do?
So
Mahesh has already mentioned this, yeah.
the molar modification of the Millard technique, sir.
No, molar modification is not that. You've already taken your incision. Now from where molar you can take? You've already taken an incision going across the base of the columella, going across to 2/3 of the opposite, till the 2/3 of the opposite philtrum.
Yes.
Now you find that it is not dropping. What do you do next? You already committed one incision.
Adequate muscle dissection.
All that is done. All that is done. This is a skin shortage, skin contracture. Muscle will maybe drop another millimeter or so, but you still have not released it. How do you address this problem? Or you leave it as it is and tell the patient to come back for a revision? What do you do? Mahesh already told you and we discussed it. One, you also mentioned there is something called a back cut.
It's a back cut, yes.
What is the direction of the back cut?
90 degrees toward.
Means basically it ends up being parallel to the opposite side philtrum.
Yes.
Right?
Yes.
Now try and imagine the defect like a bird's beak. How are you going to fill in that little gap?
From the lateral element.
How can you? Lateral element is an advancement flap. It moves in a unidirectional manner. You can't fashion a small beak from that and to fit into the defect created by the back cut. There's only one thing that will fit into the back cut. What is that?
C flap.
Correct. The only thing that will fit into is if you get a nice C flap, you can put the thing, but then there go your lip aesthetics. You're going to have a bird beak kind of thing on the visible area of the lip, which is fitted in with your C flap. There go your whole advantages of doing a rotation advancement. So what is the best method if you are falling short of rotation? Subodh mentioned it, Mahesh mentioned it. Either you're not been paying attention or you got distracted. The concept of second release, what is that?
In the mucosal surface.
Mucosal surface is all below. We are still talking about the vertical height of the cutaneous part of the lip. Subodh, tell
Yeah,
them.
and a small triangle just above the vermilion border, like you do
Yeah.
in Tennyson,
Yes,
much
sir.
smaller triangle. So now let's go to the basics again. I mean, I'm glad that you're doing Willard, but let me know.
A small request to all panelists. The questions will be framed systematically from history, clinical examination, and planning, and going to the management, sir. Because
Ayyo.
each component is given marks, the judges have to give the marks, and based on these marks, only the teams will be selected for the finals. So
Yeah, we'll keep that in mind.
kindly
Yeah.
please ask questions in the those I think you can understand.
At the
Yeah.
end. So you want us to ask questions at the end?
Not
No,
sure,
no,
sir.
no.
In the form of questions only you ask, sir, and
Yeah,
each
yeah.
component you take and ask the questions.
No, I think in
Okay, so
antenatal history and
Because,
examination, they have cleared a lot of things, right? So I want your basic aims in repair of this cleft. What are your aims? What are you going to achieve?
Subodh,
Yes, sir.
before, because madam said, so I will just ask one question regarding the previous stuff. Now, this baby has been brought to to you by the parents, and you have repaired, and the baby is fine. And then the parents ask you, what is the chance that my next baby might get a cleft? And if you, and how it can be detected, and are you aware of things, how you, and what is the percentage and all those things? Can you elucidate on that? Just because madam asked, so I'm interrupting Dr. Subodh. I'm sorry about that.
No,
So
no,
that
go ahead.
Sir, if one child is having, sibling is having cleft lip palate, the chances of the next sibling getting cleft lip palate is 4%. And if one,
Could you qualify that statement?
Like, sir,
That statement is partly correct, but it is not completely correct.
sir, if there is an incidence of a cleft lip in the one of the sibling or one of the parent, it will be like a 4% of the
No,
incident.
no. Parent and sibling are completely different.
Yes, sir.
If it is a sporadic cleft,
Okay.
no consanguinity, no first degree relatives have the clefts, and the child is born with a cleft, then there is a 4% increase for the
4%.
second child. But the moment there is consanguinity or a family history of cleft, the figure changes.
yes, sir.
Am I right, Mahesh?
yes.
When it is
And every
yes,
successive repeat relative increases the chances.
yes, sir. So if one child, sibling and one parent have cleft lip, it is 17%. And when consanguinity is taken into account, first degree consanguinous has 3.5%. Secondary
मेरी भी
so,
आपकी भी ऑनलाइन क्लास होती है नहीं होती है
Somebody is randomly talking.
Rohit, please mute everyone except panelists and presenters.
so and if second degree consanguinous is there 0.8%, third degree consanguinity is there 0.6%. Sir.
I won't argue. You probably know it better than I do. But
So, what
okay.
advice would you give to the couple?
So they can for their when they are planning, before planning the next pregnancy, they can do a genetic counseling and see whether any known syndromes or gene abnormalities are there running in the family. And if nothing is there, this antenatal scan at 20 weeks can detect cleft lip palate.
Are you aware
Antenatal
of any gene?
see,
Are you aware of any mutation or any variation in any gene that can cause cleft?
So in the interleukin regulator gene
IRF6.
IRF6. Yes.
Okay. Yeah, IRF6 is associated with lower lipids and cleft. And we were the first in Word to show that the coding region in RF6 is not linked with cleft and van der Waals syndrome as well. But what about nutrition? Can nutrition cause cleft, or deficiency of something can cause cleft?
Folic acid deficiency.
Yes.
So definite folic acid intake during the first trimester.
No, before the pregnancy happens.
Before the
Pregnancy.
pregnancy.
Yes, sir.
Because it is too late.
Now, with a lot of the folic acid supplementation, we do not see folic acid deficiency in our mothers, and it is a vitamin B12 deficiency which is seen, and it is of course the vitamin B12 is also in the folate cycle that causes the high concentration of homocysteine, and that can cause cleft, right? But now coming to the questions on planning and repair. So, what are your aims in this patient? What are the deformities that you want to correct? What is the deformity that you see? What is the asymmetry there? And what are your aims and planning in this patient?
Accurate approximation of the vermilion, mucocutaneous junction, and the nasal floor, and nasal.
Focus on philtrum. Focus on philtrum.
Filtral
What
column.
is the asymmetry or deformity there, and what will you do?
There is an inadequate and ill-defined filtrum, so we will try to achieve a filtrum of adequate length.
Oh,
What are you trying to rotate?
So you are saying that there is a difference in heights of the two filter ridges,
Yes, sir.
right? And
it's
to
oblique.
make a filtrum symmetrical, you have to make the two filter ridges equal.
Yes.
Okay, so now proceed. What will you do? And what else will you correct?
For achieving adequate length of the filtral ridges, we will bring down the medial element and release.
So your aim is to achieve the symmetry of the filtrum, isn't it?
Yes, sir.
Will you correct the columella and its direction and deformity and a nasal deformity?
Yes, sir.
And what about the vermilion thickness?
We have to achieve.
So these are the things I want you to mention, and
Yes.
the lip height.
Achieve the nasal symmetry, create a nasal floor, achieve the adequate columella length, and straighten the columella, create the filtrum column mimicking the normal cleft, non-cleft side of adequate length, getting the vermilion border and the white roll in continuity, and getting a vermilion of equal thickness comparable to the opposite non-cleft side vermilion at the cupid's peak, and adequate approximation of the muscle.
So what are the markings that you will make if you're doing a Millard? And are you doing Millard 1 or 2?
Millard 1, sir.
Okay, so what are your markings?
The peak of the cupid's bow and the cupid bow point on the non-cleft side and the distance between them.
Do you have any figure?
I think they got a
Yeah, you have,
presentation.
you display and explain.
Yes.
And we mark this point and the distance between that, and this we mark the corresponding
One second.
we mark the peak of the cupid's bow. And on this medial element, we mark the peak of the cupid's bow corresponding to the length between the cupid's bow point and the peak of the cupid's bow on the non-cleft side. And we mark the height from the peak of the Cupid's bow to the columella base, that is the filtral column height on the non-cleft side. Similarly, we mark in the lateral element the node of point. We have 4 ways of marking the node of point. The maximum width of the vermilion in the lateral element, the distance between the base of the ala and the Cupid beak on the non-cleft side correspondingly on this, and the distance between the oral commissure and the Cupid's beak on the non-cleft side similarly, and the distance between the columella base, the filtral column height, the non-cleft side to this. And
let me interrupt you one second.
Can I interrupt? There is no
Yeah,
Cupid's beak on the non-cleft side. You are deciding that point.
yes, sir.
You
So how do
understand?
decide?
No.
That-
Okay, same extending what Mahesh is trying to say. Whenever you are using whenever you have marking points for cleft lip repair, there are some objective points and there are some subjective points. Out of all the methods you mentioned for finding out the lateral point, which is going to be the peak of the Cupid's bow, which is going to join to the other side, you said measurement from the angle of the mouth or oral commissure. How reliable is it?
That is the least reliable, sir.
Why?
Because if we need a grain and height, then we can
No.
lateralize that.
That's not the reason. The pull of the muscles
Sir,
on both sides is different. On the non-cleft side, the muscle is far greater in length and attached to the base of the columella and the septum. On the lateral element, it is already bunched up to and pull the ala right outward. So the muscle pull itself is different in the medial and the lateral element. So you cannot use, and if you're saying I'll straighten it with a hook and measure, again, the amount of straightening you're doing is extremely subjective. So the only 2 really objective points are where the white roll is fading and where there is a maximum distance between the white roll and the red line. Okay, white roll and red line these 2 are objective, because whatever be the shape of the lip and the pull of the muscle, these 2 are objective features. Mahesh, you agree?
You're muted, Mahesh.
Mahesh is muted, yeah.
Yeah. That's right.
So out of all these 4 measurements, which sound very good, but the actually objective ones are only these 2, which rely on natural lip landmarks and not related to the pull of the muscle or lack of thereof. Okay?
Yeah, I mean, there is a little more to it. So when you subjectively determine where that node of point is, right? So as Dr. Mukund said, where it is fading, right? So actually when it starts fading and not where it has faded, right?
Yeah.
Second point, when it takes a direction towards the nose, towards upwards, right? So even if it is white there, and even if you see a good vermilion border, but it has taken a turn up, if
You're
you
late.
take your point there, then you will have a pseudo notch kind of thing, right? The third thing is he said where the height from the vermilion border to the red line is equal to the other side. Now here, some of the surgeons, including me, so even if the point is a little medial and this dry mucosa is a bit narrower, sorry, no, this is correct. I mean, on the lateral side, you have to take the width where it is maximum to
maximum. That's right.
Sorry,
That's right.
Yeah. On the medial side, there is a narrowing.
And remember one more thing. In any repaired lip, a horizontal shortening of even 5 millimeter will not be noticeable. A vertical shortening of 0.5 millimeter will stand out.
Correct.
You get?
Yeah.
So proceed with the rest of your marking and
Yeah, that's why we take Abbey flap and you cannot make out.
True.
So,
So then once we have made the markings and the height difference between the 2 filtral columns, next we mark it, we make the incisions. full thickness incision on the medial element from through and through, starting from the cupid marked cupid beak up to the columella base with the convexity, and we give the back cut as we go until we gain the adequate drop of the medial element, and then we have to separate the skin and the mucosa from the muscle, and the muscle should be detached from the abnormal attachments, that is the columella base, the anterior nasal spine, and the caudal septum. And similarly, in the lateral element, a full thickness incision is made, and similarly, the skin, muscle, and mucosa are separated, and the muscle abnormal attachment is released from the alar base, the piriform aperture. And if needed adequate, we can go to the zygomatic arch. And then for the nasal floor, we make a superiorly based septal flap at the oromucal junction, and lateral nasal wall, we make again a superiorly based flap and elevate, and
will it reach?
Sir, if in case we fall short, we have the L flap to compensate for
you have to keep all this in mind. Once you incise and you have taken your incisions, your L flap will become a G flap, that is gone flap. So you need to plan all this beforehand to see whether you are having enough tissue. I'm asking you one very basic question. So you have taken your lateral point based on the two criteria, and you find that the vertical height of the lip is very short. You have created the defect on the medial side, you have rotated it. Let us say you have got a good rotation. You have managed to horizontalize the cupid's bow. Now, after horizontalizing it, you move the advancement flap into the defect, correct?
Yes.
You find that it is short. What are all the tricks available for you? Are you getting my point? What the problem is?
Adequate, yes, sir. So even more adequate dissection of the muscle, and if needed, we can.
No, muscle and all is dissected adequately. Everything is fine. You have dissected it quite a bit. The vertical height of the lip on the lateral element is short. It is falling short compared to the non-cleft side. What do you do? Now you're having a huge gap. What do you do now?
Now we can lateralize cupid's peak point, that is node of point, by a millimeter or two.
Okay, you find that you do that, it still does not come. Because taking the lateralization, moving the lateral point by about a millimeter or two is not going to get you much gain in vertical height. You have to do something else. What?
Periolar incision, sir.
Very good. So you go periareolar and literally advance the cheek in the form of, you have to excise a crescent. So what you are doing is actually taking a part of the lip which is well beyond and moving it. Anything else you can do with the structures you already have?
I mean, are you going to take a perialar incision, you mean?
Yes,
sir,
that's what she said. No,
If-
sometimes you have no choice. It's going to be ugly, but you have no choice. What else can you do before that? See, everything is a step-by-step thing. You try this. If it doesn't work, you release the muscle a little more. It still doesn't work. You move the lateral point of the cupid's bow laterally by about a millimeter. Still, it's short. Before you commit yourself to the perialar incision, what else can you do? There's one structure which you have not used. No? No. The C flap itself, no?
See,
The C flap itself sometimes can be used to bridge that small gap. If it is maybe 2-3 millimeters, you can easily put the C flap inside and take care of the discrepancy in the vertical height.
No, but they are doing Millard one.
I know, but still.
Yeah.
I mean, we should not, we should abandon this Millard 1, 2, 3.
Correct. I also think so. I also think so. Yeah,
True.
I also think so.
Because whatever now which is done in Millard, we are not technically taking the peri-alar incision since the Taiwan
We
guys.
don't. Yeah. In
So
fact,
like,
we
you know,
don't.
we don't
You
need
don't
to
even
technical.
correct. You don't
Technically,
even
there is
commit.
no advancement flap. So what is actually filling the rotation defect is not the tip of the advancement flap, but it's actually the C flap, which is going into the rotation defect.
Right. And now, so you must remember one more thing also, that the advancement flap, whether you take it in the classical Millard form where you have incised it. Nowadays, we don't take a transverse incision at all. We stop at a vertical incision and move the ala and the lip component more or less together, which is what I think Mahesh was trying to say. So
Yes.
you need to incise it precisely if you find the lip is very short. If you incise it, the lip drops a little bit and you fill in that little gap with your C flap. But remember one thing, that the advancement flap is a pure advancement flap. In other words, it just moves across. It can't change any dimension at all. So, are we allowed to ask questions on alternative systems, madam, of repair?
Yes, sir.
All right. Tell me about the triangular flap. What is the biggest plus point of the triangular flap repair as compared to a rotation advancement? The two biggest components. You may not have done it in your unit. Sorry?
Accurate geometrical measurement of the filtral deficit and
That's fine. That is fine. The markings are very precise with very little scope for error, and all that is fine. But as you know, when Dr. S.K. Vatnagar used to be very fond of asking us in exams, when will you not do a Millard, a rotation advancement? When will you not do a Millard?
He required a specific answer.
No, he required 2-3 specific answers, but 2-3 indications where I'm not talking about people like Subodh who have done a zillion clefts. I'm talking about the average person who is doing clefts.
Yeah, the first thing we were taught was the wide cleft.
Wide cleft.
It's not. No. It's not just wide. You see, there have to be.
And if the Cupid's bow has to come down significantly,
correct.
Then you require additional of tissue.
Right. If the rotation is very severe. Number two, if the lateral element is very short. Every cleft is different. Sometimes if the lateral element is very long, what will you do? You have taken your mark correctly based on the Nudov principles, and you find that the lateral element is very long. What do you do? It's longer than the defect created by the medial rotation. What do you do?
Ideally.
No, ideally. What do you do? There is no question of ideally. Every lip is different. And you can ask the man who has seen the most number of lips. Every lip is different. You have a situation where the lateral element height is much greater than the defect that you created after doing a rotation. It is possible. It is extremely possible. What do you do then?
We can give the triangular incisions on the alar base and just above the vermiculum, and we can excise the triangle and we can close it.
So you excise from the nostril sill.
Yes,
Basically, that is the only area where you are allowed to excise from the nostril sill in order to balance it out. Now, the other end, if it is extremely short, which you already answered. Now, tell me the advantage of the triangular flap method as far as the lateral lip element is concerned. The huge advantage that the triangular flap method has, which the rotation advancement does not have.
So in the rotation advancement flap, the scar will be in the upper portion of the.
No, nothing to do with scar. It's nothing to do with scar.
There is one thing which is in a triangular flap, one thing which distinctively is better than a Millard is one thing.
The word advancement. The word advancement is the key. In a Millard flap, it just advances. There is no change in any direction, up, down, it advances. Whereas in a triangular flap method, depending on how the flap moves like this, you understand? You have opened it out and the flap moves like this. So it's a multi-dimensional movement of the flap, where this is your line, that your primary line, this is your triangular flap, and initially it is something like this, but it opens out. You get my point?
Yes.
Of course. So the triangular flap method is a composite movement of the lateral lip element into the defect that you have created by your markings. Whereas in a rotation advancement, it is a unidirectional and unicomponent movement. So in what Dr. Bhatnagar, if the lateral element is very short, if the Cupid's bow rotation is very, very severe, you can do a Millard, but you be prepared for some amount of shortening and deformity and the possibility of maybe a redo surgery at a later date, which is not wrong, Okay, one of my professors used to say that every wide clip is a lip addition, which is going to require, in more than 90% of cases, a lip revision. This is what he used to say.
So while I agree with most of the things that have been said by Dr. Mahesh and Dr. Mukund, and about the vertical height and the length of the lips, so I have tried all those methods that have been discussed, but the best is to do nothing. So if the vertical height is more, that can happen in some of the incomplete cleft lips, just do not do anything, just a differential suturing. And a good muscle dissection and a differential suturing will take care of any difference in the height as well as in the length of the lip, right? So, and as Dr. Mukund was saying, so I agree that initially also I was differentiating in different procedures. So if the cleft was wide, if the medial edge of the cleft was much thinner, there was not full, and the lateral lip was shorter, then, and the most important thing was the difference in the two filtered ridges was more than 3-4 millimeters, then I would choose a triangular flap. Otherwise, a rotation advancement will do. So that would mean that the rotation advancement had that kind of limitation, and that is why people started using a small triangular flap in addition to the rotation and advancement at the lower end, right? But now proceed with your muscle dissection. I want to hear about that too. What kind of muscle dissection will you do medially and laterally? What dissection will you do at the base of the ala and columella?
And what plane? What plane is the muscle?
What plane? Yeah.
On the skin side, what plane?
Proceed.
Subdermal dissection, sir, on the skin side.
Correct.
And on the undersurface, subperiosteal dissection, sir, to release.
No, the muscle dissection. How will you separate it from the mucosa?
What plane? You said subdermal dissection for the skin, which is correct. Which is, so you basically literally leave a very thin dermis. Otherwise, you will miss out on the muscle fibers. And how do you have you noticed one thing? What happens when you do muscle dissection? You never see it clearly. Why is that?
Because it has dermal attachments.
No. Your infiltration. If you wait for a little time for the adrenaline effect to go down, you will find that the muscle will restore its normal color. Of course, if you have experience, you know exactly where to do it, but sometimes you don't see the red of the muscle for the reason of the action of the adrenaline. So, on the external surface, it is subdermal, extremely thin skin. Fine. What about deep surface? Mucosal side? What is the plane?
Submucosal.
Submucosal means how far is it from the depth from the mucosa? You know those glands that are there, mucous glands?
Yes.
In the lip, make sure you don't go through that. It is a very large distance from the mucosal side. On the skin side, it's very small distance, but from the mucosal side, it's a very large distance. If you try to save other mucosa, you think that this is the muscle. Actually, you're going through the submucosa. It will start oozing and saliva and blood and all that. So you have a fairly large distance on the mucosal side. Then what did Subodh asked you specifically about the ANS and the septum and the alar base? What about that?
This abnormal attachment should be released on the medial side from the base of the columella, the caudal septum, and the anterior nasal spine side, and on the lateral side from the alar base piriform aperture.
Piriform aperture. Okay. Alar base, yes.
And
How
Are
far
you going to
lateral?
give an incision in a piriform aperture?
Hmm?
Are you going to give an incision in the piriform aperture towards
No,
the
sir.
tip? No.
You just dissect the muscle.
No,
Up-
muscle, no. He's talking about release.
Release from the piriform aperture.
You have not
Yes.
understood his question.
So if you go to the Eller base and from the medial side of the Eller base, right, or when you are going through the sulcus, right, and you are separating, do you separate the Eller base from the alveolus and go up into the piriform aperture and separate the nasal vestibular mucosa and skin from there, or you don't?
And do you need to cut? Do you need an incision in the piriform fossa?
Yes,
See,
sir.
one hint I'll give you. You are going to take an L flap. Are you not?
Yes, sir.
So when you are taking an L flap, how do you base the L flap? When Millard described the L flap, it was based on the alveolus. But now the L flap is not based on the alveolus. Where is the L flap based on? Then you will understand what Dr. Subodh is talking.
Where is the position of the ala in compared to the normal side?
It is posteriorly and inferiorly displaced.
Severely retroposed.
Retrocaudal.
Yeah? The retroposed. It is retroposed in compared to
Retrocaudal.
the normal other ala. And if you have to bring the ala up, you need to incise somewhere, no?
Yes.
I don't think in some cases it will not stretch. If you dissect it all around and try to pull the ala up, in some cases it might stretch, but in many cases you need to incise and create a defect in the piriform fossa. If you don't do that, your alar base will not come up to the anterior level of the normal side. And that's what Mahesh was trying to say, is that you have to base your L flap so that you may need the L flap to plug this hole. If you don't plug it, it will go back. Okay, it will go back. May not, your lip repair may still hold good, but the ala is going to go back.
Because that contracture you have released but not resurfaced.
You have not filled it, exactly. So you need to, what Dr. Subodh was asking was the same thing. Do you incise the piriform fossa? In many cases you have to. If you have to bring the alar base anteriorly, you have to release it. You have to cut it somewhere in the anterior posterior dimension because it's a very fixed distance.
Okay, so much of dissection done. And what about the frenum? Do you cut the frenum or you don't? Will you cut it or you won't?
Mostly we try to preserve it, but if we need gain in length and to resurface the mucosal surface, we need to cut it.
So there are three major elements where there is a contraction: the skin and the muscle and the mucosa, right? So you have cut the skin, brought it down. You have separated the muscle from the base of the columella, brought it down. What about mucosa?
Mucosa, like medially we can cut the frenulum, release the frenulum. Laterally we can make an incision into the mucosa up to the just short of the parotid duct opening.
No, parotid duct opening is not there. I mean, you don't need to go that wide, right? So, but you will give a sulcus incision to release that, right? So that's good. So you're releasing all the three elements because there is shortening in all the three elements. Good. Go ahead, suture it. What about nose? Will you do something to the nose because your nose was much deformed? So what are your plans for the nose?
Sir, a closed rhinoplasty, sir.
How will you do that?
So separate the left side lower lateral cartilage, and both the lateral crust and the medial crust, and the retrocolumnar space. We have to dissect the fibrofatty tissue of the both medial crust, and once it is all separated, the transdermal sutures and the suture between the lower lateral cartilage and the upper lateral cartilage, and the another suture between the lower lateral cartilage and the opposite side upper lateral cartilage to make the obtuse angle acute and prevent the alar flattening, rim flattening.
Okay, how will you suture the muscle and what sutures will you use?
No, before suturing the muscle,
Yeah.
Subodh, can I just
Yes.
interrupt?
Yeah, go ahead.
Yeah, so you are now before suturing the muscle, you have to do the nostril floor repair.
Yes, sir.
So
Yes.
you have not
So-
dissected anywhere for the nostril floor repair. So you neither gone on the medial side nor the lateral side. How are you going to close the nostril floor repair? And you said something about the septum. What do you do to the septum?
Yes, sir. So told about this superiorly based septal mucoperitoneal flap on the medial side and the lateral wall superiorly based flap at the lateral nasal wall. And if the septum is involved, we can do a septoplasty by scoring on the non-cleft side by raising the mucoperiosteal flap if needed.
Don't score the pediatric cartilage. Just dislocate the septum. I mean, that is, yeah, from the
The
vomerine crest.
Yes.
Yeah, and yeah, it will fall in midline. Sometimes very senior surgeons used to take a strip of 1 or 2 millimeters, but that's a controversial thing. But at least you dislocate the septum, you know, with the but never score cartilage, you know, for in a child, please.
And
So now
one
go to the muscle dissection as Dr. Subodh said.
is the muscles we approximate with forovicral matter sutures, sir. And the mucosa with forovicral and fibovicral, and the skin with sixoethylone, sir.
In way?
So, and one, sorry, sir, dermal sutures with vicryl, sir, fibovicral.
And skin?
With sixoethylone. Ethylone, sir.
Ethylone. Okay. So what are the other options for skin?
Skin we can do with tenoethylone and leave it, or
Tenoethylone.
glue, sir.
Yes.
And taping.
Yeah.
And
What about vicryl rapid?
rapid vicryl,
Observable
sir.
suture like rapid vicryl can be used.
How soon does vicryl rapid absorb?
It has a half-life of 14 days.
Yeah, so by the time the scarring is quite bad. Remember one thing, any absorbable material is absorbed or resorbed, whatever you want to call it, by an active process of hydrolysis and a tissue reaction. Otherwise, it will not absorb. So even though vicryl rapid, they say it looks good, but on lip somehow, I don't know.
No, it
doesn't
does.
look good.
It does leave a scar, right? So
Yes,
even the
yes,
vicryl rapid does leave a scar. During the
Absolutely.
COVID time, we started using vicryl rapid, but now we are stopping to use
Stopped it. Yes,
vicryl rapid. Yeah.
Yeah, and especially it is very unpredictable because couple of times for my bilaterals, I had issues that fourth or fifth day when they were cleaning, there was no IP rapid sutures. It is very unpredictable.
So the
Ethylone is a
post-operative care. Let us come to the post-operative care, right? So how will you prevent
sorry
the
to
case?
interrupt you, sir. We'll continue this discussion during panelist time. Time is over for the discussion, so I express my sorry. We'll continue this after
Madam,
finishing the other sessions.
One last question.
Okay.
Will you give general anesthesia for suture removal?
Sir, we won't give, sir.
How do you hold the child?
Sir, we give trichloral syrup, mummify the child, and then.
Okay. Good.
We'll postpone the PG's question session to end. We'll finish the next sessions as Mukund sir would like to need to go urgently.
Would no, like no, have to.
Have to.
Somebody is admitted, yeah.
Yes, sir.
Who is handling the questions? I mean, who's answering?
The PGs only.
So somebody take it up.
You can see the case and tell the diagnosis.
It's like
You can watch the findings in the CT also.
Yes.
it looks like
Anybody?
retroganthia, microganthia is present.
Sure. See,
Looks-
observe once the all clinical photos and the CT film and come to diagnosis.
See the
Diagnosis.
photos first.
See the photos.
Photos also you see, clinical photos. The incisors lost, but
It's very obvious.
Okay, look at the mouth opening. I'm giving you the
yeah,
straight.
mouth opening.
TMJ
TMJ.
ankylosis.
Yeah, yes,
TMJ.
yes.
TMJ ankylosis, unilateral, bilateral.
It's a CT.
No, before, no, go back.
Come to the photograph first. Come to the photograph.
Clinically
Look at the
also you can.
photograph. Which side of TMJ is which side of TMJ ankylosis is it? Just looking at the photograph. Look at the second middle photograph on the top and tell me.
Left side.
Left side.
Left side,
TMJ ankylosis.
Correct. Why?
Because the chin is deviated
to
to
the left
the
side.
involved side, sir.
Towards the
Affected side, sir.
yeah. Why did that happen?
Because of the differential reduction in growth of the affected side, the chin is pulled towards the involved side, sir.
Because there was a
Okay.
normal growth on the
Ramus.
right side and it was reduced on the left. Isn't it?
Yes.
Okay, go to the CT then. Now, what do you see here?
Tell the findings.
The 3D reconstruction of the face, the condyle is completely involved. The
What do you mean involved?
Ankylosed part, it is like complete bony ankylosis.
bony ankylosis.
So you can see total, there is no semblance of any normal condyle. Instead, you see that there is a bony fusion there. And anything else you notice?
Coronoid process is
Yeah.
involved, not involved, sir.
It's enlarged.
No. Coronoid process is
Enlarged.
enlarged,
No,
you mean
no.
elongated.
Elongated. Yes.
Yes.
Okay, why does this happen? I am telling you that if you lose around 1.5 centimeters of vertical height and the mandible is shortened, the condyle is definitely going to poke above the zygoma. Argue with me.
Say what has happened to the coronoid and the condyle. If you see the condyle here, right, and see the coronoid,
Yes.
what has happened to the condyle of this patient? And
Condyle is fused, sir.
Condyle is fused here,
Fused.
sir.
Yes.
That is a
Yes.
It is short, so it has gone up. So where will the coronoid go?
Yes.
It should go up.
It has
It
gone.
will anyway go up.
Yes, sir.
It go up.
Yes,
That is
but
right.
in addition, there is one more factor. What is that?
Temporalis full
Compensate along.
full of
Yes,
stem.
full of the temporalis will cause that. Anything else you notice?
Ramus height is decreasing.
Okay, you can't say that unless you have seen the opposite side, but yes, ramus height will be decreased. Anything else?
Sigmoid notches
Yes.
And,
Sigmoid notch is
Until-
more or less intact because of sigmoid notch is
until-
more or less intact because of the overlap of the zygoma. You can't really see it. Sigmoid notch has also gone superiorly because of the shortening of the vertical height. One more feature is there, which is classic of TM joint ankylosis.
antigonial nerve.
Correct. So why is that?
Masseter pull.
Pull of the masseter. So just pull of the masseter. Why you should cause a notch?
Sir, due to the TM ankylosis, used to keep on try to open the mouth, sir, so that makes the hypertrophy of the masseter, which causes
Nothing to do with hypertrophy. You must understand that facial bones are membranous bones.
Yes.
They respond to stress. If you
Yes.
take a 2-month-old child and keep your finger on the mandible and keep it pressed for 20 minutes each day, after about 15 days, you will have a depression. Okay, so the bones are always responsible. The whole. So if you read the chapter on our McCarthy, Mahesh will remember there was a chapter called Facial Growth by Donald Enlow. The whole concept of piezoelectric forces, and it is very adaptive. Now,
Yeah, the wherever there is, how it grows, there is positive stress on one side, negative stress.
and negative stress on the other side.
So the
Right.
bone is
Yes.
laid down on one side and absorbed from the other side. That is
Other
how
side.
the cranium grows.
Okay,
Yes.
so since they have not shown the other side, we presume it's a unilateral ankylosis. Can it be
Yes.
bilateral?
Bilateral possibility.
But with not so severe.
Or not so severe? Can you find another word for it? Fibrous ankylosis. It's
Fibrous.
possible. No, it's possible. Now, what do you think was the cause of this?
Sir,
Childhood
trauma to the bilateral subcondylar have been happened with heel.
Bilateral, unilateral.
No, I mean, in this case, is unilateral, sir. With heel.
So, childhood trauma. Have you seen any? Have heard of congenital TM joint ankylosis?
Yes, sir, congenital TMJ.
Yes, sir.
I have seen one in the last 30
Yes.
years. Anyway, so it is known. So, childhood trauma with unilateral fracture, which was not treated properly. The normal sequence is that bone is laid down, callus is formed, though membranous bone callus is not as dense as that of long bones. It gets replaced by bone and the whole thing fuses and gradual reduction of mouth opening. And if you
Yes.
look, may not be very clear, there might be an injury of a scar on the chin. So if you have a clinical case, make sure you look for that. All right.
So what are your options for this condition?
Sir, counseling.
Yeah,
Counseling.
how will you counsel them? And what will you do for this child?
What are your aims in this?
Its aim is to achieve the mouth opening, sir.
More than 3 centimeter, 3.5 centimeters.
Okay. Only mouth opening or
And
anything else?
to get a proper occlusion.
Okay, that's already there. Okay, maybe a bit of crossbite. Anything else?
Crossbite.
And to get a proper.
What do you see in the profile?
The
facial
retrognathia is
profile
there.
lead to that.
Retrognathia is there.
So, we will-
So first aim is for functional, right? Next
sir.
aim is to restore the aesthetic appearance
Yes,
also.
Facial,
Okay?
facial profile
Yeah, even if you see the chin, it's deviated to the
affected side.
affected
Is-
side. Okay.
Is there a facial cant? Is there an occlusal cant?
Yes.
Looks like.
Occlusal cant is.
No.
Yes.
Tell me about
sir.
occlusal cant. When will occlusal cant occur?
Where the maxillary and the mandible teeth join together.
So
The
when the-
plane that they join together.
No. So that is you are telling me the definition of occlusal cant.
when there's a
Occlusal
significant
cant when there is a occlusal
Significant
plane. The occlusal plane is inclined.
Yes, sir.
When will an occlusal cant occur?
when there is a significant difference between the mandibular ramus on the both sides. Sir.
Again, that's fine. We are talking about the definition of occlusal cant. When will it occur in a patient? I'll give you an example.
Yes.
Suppose the patient has TM joint ankylosis at the age of 16 years. Will you have an occlusal cant? The mandible is shortened. Will you have an occlusal cant?
No.
Huh?
No.
sir.
Why?
Eruption is already.
No. There has to be growth.
Growth, no growth.
So if you see a patient, if you have, let's say the child has sustained a trauma at the age of 2 years, and you see the child before the first growth phase, you can avoid an occlusal cant if you do the release before the growth occurs. Once the growth has occurred and the occlusal cant has established itself, now you have no option but to yes. What do you have? How will you treat an occlusal cant, established occlusal cant? Ravi said this, no? Aesthetic restoration.
Yeah.
One other thing is restoration of the bite. How will you treat an occlusal cant? We are coming to primary surgery a little later. First, let's test your concepts. The patient comes with an occlusal cant, clear cut, because why? The left side has not grown. Because the mandible is stuck, it does not allow the maxilla to grow. On the right side, the mandible is free, therefore the maxilla pushes the mandible down, and therefore you have an occlusal cant. Correct? How will you treat occlusal cants? One jaw surgery or two jaw surgery? Am I still connected?
Yeah.
Okay, there was profound silence, so I thought, yes, इतना सन्नाटा क्यों है भाई?
अभी आप ऑर्थोग्नाथिक में घुस रहे हो.
Orthognathic नहीं, common sense में घुस रहा हूँ. Basics of occlusion. Remember one thing. If an occlusal cant is established and you elongate the mandible on the side that is short, the maxilla is not going to catch up with it unless there is still some growth left.
Yes.
A simple, okay, simple fundamental principle. So if you see an occlusal cant at the age of
Sorry, sir.
Yeah.
Sir, our connection got disconnected, sir. Sorry, sir.
Okay.
All right. If you see an occlusal cant in a situation where the facial growth is complete, single jaw surgery will not work, because even if you elongate the mandible, the maxilla is not going to catch up with that. So
Yes.
if you're treating occlusal cant after the period of growth phase is over, you have to do double jaw surgery.
Yes, sir.
So therefore, if you treat this child sufficiently early and get elongation of the mandible and adequate mouth opening, there is a good chance that you may be able to correct the occlusal cant on its own, because the child still has growth left.
Yes, sir.
Are you understanding? So when
Yes,
Ravi
sir.
was talking about long-term rehabilitation, you have to keep this also in mind.
Yes,
Not
sir.
only anterior posterior, but also the occlusal inclination. All right, let's go back
Yes,
to
sir.
primary surgery. So first you will counsel the child. You will counsel saying what?
We are aiming to achieve adequate mouth opening by
By go back to the X-ray now. Go to the next slide. Might be a
Sir.
little easier. Go to the CT scan. I mean, sorry. Yeah.
by
So what is
doing
Yeah.
gap arthroplasty
gap?
because
Gap
of the
arthroplasty.
bony.
No. What is gap
Sir, actually,
arthroplasty?
resection of the unclosed parts, sir, bony uncloses.
Right.
Yes, sir, and release. And
Right.
if we are not achieving any adequate release, we will go for the coronotomy on the same side.
Right.
And even then, if you are not achieving adequate opening, we will go for the contralateral side of the fibrous ankylosing release if there is any, sir.
No.
Yes.
Don't. We'll come to that later on. First, stick to
Okay,
this
sir.
side. That is controversial, and you're not completely correct. You're partly correct.
Okay.
So you first
Okay.
you have to release the bony ankylosis.
Yes, sir. Resection. Yes.
So the
Yes.
concept of previously, again, they used to ask questions like, do you take the superior incision first and the inferior? It doesn't matter. You have to create a substantial gap.
Yes,
so
sir.
that of at least 1.5 centimeters. Why?
1 to 1.5 centimeter we have to release.
Why?
Otherwise, the fracture will unite.
Not
Yes.
the parts will unite again. So to prevent
Yes, sir.
re-ankylosis.
Re-ankylosis.
Okay.
You are
Now
causing a pseudoarthrosis.
how do you fill that gap?
With local options like buccal fat pad or the temporalis
myoplasty. Interposition temporalis.
Interposition temporalis muscle.
Muscle or fascia. Sir.
Fascia. You have created a 1.5 centimeter gap and you are putting a 0.1 millimeter fascial thickness.
Muscle.
Which fascia? Deep temporal fascia or superficial temporal fascia?
Muscle, sir.
Superficial temporal.
No, don't say everything at once. Superficial temporoparietal fascia, what is the thickness of that?
Very thin.
Extremely thin.
Yes.
So now go up the ladder. Will you use temporalis muscle?
Yes.
Yes, sir. We can do.
What will happen to the temporalis muscle? So what is the blood supply of the temporalis muscle? Sorry, TM joint is my all-time favorite topic. Anyway, what is the blood supply?
Deep temporal arteries.
Anterior, middle, and posterior branches
branch.
of the deep temporal, which is a branch
Yes.
of
Maxillary
maxillary. Maxillary artery is a branch of the maxillary artery. So you can get a vascularized bit of muscle and you can plug it in. What happens to the muscle?
Muscle will go for atrophy.
It will instantly atrophy.
Atrophy, yes.
Okay.
Sir. Yes,
You have
sir.
released it from the origin. You have put it down. It has no insertion. It's lying loose. Even though the blood supply is extant, this is excellent. This muscle is going to atrophy. You are going to
Yes.
have a good chance of recurrence of the ankylosis.
Yes.
So you need to plug something in there that is going to maintain the vertical height.
Yes.
And which has less chances of
atrophy or resorption.
Right. Now tell me about the costochondral graft. Have you heard of that?
Yes, sir.
Yes, sir. Costochondral.
How does it work? How does it work?
Because in the child, the chondral part has
Growth potential.
And
No, condyle of the mandible has got growth potential.
No, so this costochondral graft which you are taking.
Wait. What type of growth is the mandibular condyle? It is it's a propulsive growth. Okay, in other words, the growth center actually pushes the mandible downwards.
Yes.
That is as far as the original condyle is concerned. Now this condyle is gone. Now what do? You put a costochondral graft. How does that work?
The cartilage part and the perichondrium has growth potential.
Really?
But
in what form? What is the difference between the growth of the cartilage portion of the costochondral graft versus the original growth center of the mandible, the condyle? What is the fundamental difference between the two?
Whether inchondral or...
No. The costochondral graft is an adaptive growth potential. In other words, if you put a cartilage element and the growth of the maxilla pushes the mandible down, now layers of cartilage are generated on top of the cartilage cap. There is no intrinsic growth potential in a costochondral graft. It is what is known as adaptive growth. Because you have released the ankylosis, you have freed the mandible. Now the maxilla, again, this can only happen when you catch the child in a very early stage, say 5 or 6 years. After that, it's unpredictable. So at this stage, when the growth of the maxilla is now unhampered, the downward growth of the maxilla is unhampered because the mandible is free, it pushes the mandible down, and now layers of cartilage are oppositional growth, not a primary propulsive growth. How much cartilage will you take in the costochondral graft?
1 centimeter.
1 centimeter or less. Otherwise, what will happen?
Vertical height difference.
No. You can cut short the bone. That depends on how you fix it. It will snap. It will snap at the costochondral junction. We have also burnt our fingers by going back inside and taking a fresh rib. If you take more than 1.5 to 0.75 to 1 centimeter, it will snap at the costochondral junction. That is why you keep a very small. That's more than enough. All right, it's more than enough. You don't need more than that. Now, so that is you are releasing the ankylosis and providing a potential for appositional growth of the cartilage. That is the basic role of interposition arthroplasty.
Yes.
Now, temporalis muscle, temporalis fascia, all these are going to atrophy before you leave the OT. Okay,
Yes,
they are
sir.
very poor and they are not high chances of re-ankylosis.
Yes, sir.
Now tell me the procedure. What incision?
Auricular
Yes.
incision, sir.
Mhm.
With
And extension above?
extension into
Hockey stick
hockey stick pattern into the
about this.
zygoma.
All right. It's okay. It doesn't matter. Question mark, hockey stick. Even if you
Hockey
angulate
stick.
it anteriorly, it's okay. Then
Yes.
what do you do?
And
Before
then,
before that,
yes, sir.
is there any particular view of the CT scan that you would like to see? You have seen
Lateral
your
Yes, sir.
lateral oblique.
Yes, sir.
What?
Sir, axial view, sir.
Axial views. I don't agree. I would like to see a coronal view.
Okay.
Why? Okay means what? Why?
So the ankylosing bony ankylosis, like extent of the bony ankylosis, whether it's going for the base of the skull and the mastoid process is involved.
That you can
Median
see in
extent.
other view also. You want to
Yes.
see how thick is the ankylosis.
Yes, sir.
Okay. Yeah.
Because
like
when
the
you are
depth,
the depth
yes,
of the
depth,
ankylosis.
yes.
Because when you are burying it, at some stage you need to be careful when you reach the medial edge. So you need to have an idea about how thick the ankylosis is.
Yes.
What is the danger in TMJ release?
So medially, if we go, we can injure the maxillary plexus of veins.
Just called pterygoid plexus. Yeah, you can
Pterygoid plexus. Bleeding
can
is
injure that.
Bleeding.
Yes.
If that happens, what do you do?
Sir, we will give compression.
Embolization.
Compression can be given. So even if it is not stopping, we can go for the external carotid ligation.
On table?
Embolization.
असल में ऑर्डर तो नहीं है अभी मैं बोलूंगी मुझे तो रिटन ऑर्डर दीजिए क्यों नहीं कर
Somebody please get off.
यस तभी तो करना
Rohit, mute others.
Yeah. So no. You realize this is one of the most difficult problems. Your ankylosis has not been released. Your burr has gone through at one point because you have been a little careless and has injured the plexus, and now it's bleeding.
Yes, sir.
Yes.
There is literally nothing you can do. If you can hurriedly finish the ankylosis with an osteotome, switch to an
Yes.
osteotome, remove the burr, crack it, take a chance, distract the mandible, and then pack it.
Yes.
Okay.
In one case, we actually packed it, sent the patient down for an angio, and 48 hours later, we had completed the ankylosis. If there is any complication ankylosis that we have not had, I don't think that we opened the dura also once. So you need to know the mediolateral thickness of the ankylosed
Yes.
block so that you have
Yes.
a fair idea of when you are approaching the medial most part of it.
Yes.
Okay, you need to
Yes,
create
yes.
a gap of 1.5 centimeters and you need to plug that gap. Otherwise, the mandible is going to rise up again because the teeth in this case are deciduous. They're not going to form any real resistance to the mandible from riding up. All right, and we
Yes.
will have a high chances of a re-ankylosis.
Time is over, sir. For
Yes, sir. I will take your leave, madam. Thank you all.
only one more.
One more question. Want to ask them about that last case. How do you think this patient will be anesthetized, and what will be your role there during anesthesia?
Good.
So this case.
For which case, sir? The TMJ ankylosis.
Yeah.
Fibro optic.
Intubation, sir.
And what will be
Five-
your role? And is that the only way, or you can do something more?
It's
Sir,
not available.
if vibro-optic is not available, then submental intubation.
Submental is not intubation. Submental is not intubation. Huh? Please don't
Yes,
get
sir.
this wrong.
You get the
Submental
tube out. You just get the
retrieval.
tube out. It is a
Yeah,
retrieval.
submental retrieval of the tube. Either force or the passage of time has created a big hole in the front of his mouth, but that's not enough for you to intubate.
Tracheostomy.
Good.
Tracheostomy.
Good. Tracheostomy is an option, but it should be reserved as a last resort. Always, whenever you do TM joint ankylosis, even after you have done 100, you need to keep a tracheostomy set ready at all times.
Yeah, so you be washed, prepared while the patient anesthetist is intubating the patient, right?
Yes.
All set to do a tracheostomy right there.
Okay.
Correct.
Madam, I'll take your leave. I have to rush to the hospital. And thank you all. And sorry,
Thank you, sir.
Thank you, Mohan.
went a
Thank you.
little, I went
Sure.
a little overboard in the last case, but it is one of my
It was interesting. Thank you.
favorite. Yeah,
Thank you,
thanks.
sir.
Bye.
Thank you.
Bye.
Thank you.
I request other panelists, please go ahead.
Can we follow the
Yeah.
order, ma'am? Right now, first we'll move to the spot.
You will ask the panelists. Okay. We'll finish the spotters.
This looks like a ulceroproliferative lesion of the involving the right occipitoparietal region of the scalp, most likely squamous cell carcinoma. We will like to go on to confirm a diagnosis with an edge wedge biopsy and to know the depth of the lesion with the CT scan and nodal evaluation, the CT contrast, neck with contrast, and then to assess the general condition of the patient according to his age, the blood workup, chest X-ray, ECG, and echocardiogram is needed. And after counseling and I'd like to proceed with the wide local excision margin. Since it is more than 5 centimeters, we'll give a margin of 2 centimeters and depth 1 layer below the involved layer according to the CT. If periosteum is involved, we'll take the outer cortex and once a biopsy clearance margin is confirmed, if we'd like to give a flap cover, free ALT flap, and recipient vessel to the superficial temporal vessels, and if there is vessel mismatch, vein graft can be used and anastomose to the facial art. And neck node dissection if involved.
I request a panelist to ask the questions. They go on telling otherwise.
Yeah.
Okay.
So you directly will go to the free flap. Is there any option of coverage?
What are the local regional options?
Sir, we can do if after excision transposition flap based on the occipital vessels.
Yes.
And,
How many flaps do you think it will be needed? Think one single flap can cover?
No, sir. The 2 transposition flaps. The medial side with the occipital artery based transposition flap and the lateral STA based transposition flaps.
Yeah. So what is the advantage of a local regional flap there? What do you estimate the age of the patient to be?
Old age. Thing like old age.
Yeah.
40 to 50.
Okay. Anything gray hair. Okay. Like all of us. So the local regional flaps will be better because you can just finish off in one shot straight away. Okay.
Yes.
But
Yes.
transposition flap, what are the other problems?
We will have graft donor side, sir.
And dog ear will be large.
Large
Dog
dog
ear.
ear
Yes.
at the point of tension.
Okay. In this case, at least 2 transposition flaps will be there, as you mentioned,
Yes.
from the right
Yes.
side one and from the occipital side. Both of them should be able to cover. But
Yes.
have you ever seen a free flap being done for the superficial temporal artery?
Sir?
Have you seen a free flap being done for this defect?
Yes, in Pascal, yes, Pascal behavior.
Yeah. What are the options available?
Free ALT flap you can use.
Lattice
Anterolateral type
Yes.
flap is
LD
Okay.
with
LD,
Yeah.
free lattice methods.
Okay. So what is the advantage of a LD or what is the advantage of a ALT?
sir,
Large defect with a muscle filling we can give, sir.
Okay.
Yes.
and this
Uh,
in a single flap we can cover the region and
Yeah. That's
Yes.
one advantage because we can always cover it
Large.
with a single flap and doesn't
Yes.
have a donor site effect.
Morbid.
Other hair gets retained. Okay.
yes.
That's the advantage of a free flap. But one
sir.
problem with ALT is unless the patient is very thin, it will be sitting on like a big bun
Big
on the
bun.
hair.
Blob.
Okay. On the head. But most of the time you see the superficial temporal arteries, they may not be very great. Okay.
Yes.
To take the load. You might need to go down to the facial also.
Yes.
Those cases. Okay. Then you can go get away with a partial cranial replacement.
What's this?
Yeah, you said only the outer table you'll be able to take. In case the
Yes.
inner table is also involved, anything else
Yes.
we'll have to do.
Sir, Dura we
How
have
will you
to
confirm
take.
it? How will you confirm it?
With the CT. sir.
CT.
CT imaging is.
Okay. CT imaging will be able to at least it'll give an indication of how much of mild involvement is there. But the final pathology, as you said, one layer below, and
Yes.
again do the biopsy. In case the entire cranial table needs to go, what will you do?
Dura we have to remove and dural patch we have to put.
Okay, in case Duras may not be involved, we are talking about something like a cranioplasty here. So what are
Yes,
the
sir.
options available?
Cranial?
Cranioplasty, titanium
Uh,
plate or
alloplastic or autogenous, like a split rib graft also we can use. Sir.
Okay.
Yes.
So will you
sorry to
be doing
interrupt,
it primarily or will you be doing it for at a later date?
at a later
date.
Sorry to interrupt, sir. We have one more
Yes.
minute for this case.
Yeah.
Thank you, sir.
Later date after the completion of adjuvant treatment and also.
Yeah, that's because always we never know how much of this thing is going on. So always
Yes.
it's better to confirm with a histological examination that all the thing is cleared up. And after observing for the patient decides and he desires, we can go for a cranioplasty. What are the types of cranioplasty available? Well, you said split thing, then titanium mesh.
Yes.
Anything off late?
So, anything?
Anything with the 3D reconstruction? What are they doing it right now?
Yes, sir.
It's a bioprinting. 3D bioprinting.
Okay, right. That's called the patient-specific implant. Okay.
Customized.
Yeah, customized.
Yes.
Okay. A customized patient, just according to the defect, they can customize it and reshape it nicely so that your originally job is to go inside, keep it
Yes.
and come out. Okay. Leave it the plan. Okay.
Yes. 3D reconstruction of the CT face, showing the left-sided parasymphyseal and the subcondylar fractures.
Okay. What do you think the nature of injury was?
Hit over the chin.
Over the chin.
Chin.
So what happens when it hits over the chin?
So a direct impact causes the parasymphyseal and the indirect impact of indirect forces higher causes the subcondylar fracture.
Yeah, the transmission of the force higher above causes another weaker link in the area. That is okay.
Yes.
So how will you? What are the problems in these cases?
There will be a malocclusion because this is a separate segment and
mouth
opening because the muscles attached will be under.
Okay.
Mouth opening will be difficult.
Yeah.
So,
How will you manage this case?
After consent
consent,
and explanation of
explain the patient regarding this procedure of putting arch bars, IMF loops, and internal fixation, and
Arch bar,
post-operatively,
IMF, internal fixation. Okay, then
and post-operatively he should
under
be
what
maintaining
anesthesia will you do?
general anesthesia.
nasal intubation,
intubation.
north-facing nasal resurface.
Okay. Nasal intubation. Why nasal intubation?
Because post-operatively, if needed,
Arch bar.
arch bar placement, it should not come into a way. And, occlusion, we have to check intra-op.
Yeah,
Okay.
intraoperatively, you need to check the occlusion.
Yes, sir. Intraoperatively, we need to check. For
Yes.
occlusion and arch bar.
Okay. Arch bars, you always put it?
Yes, sir.
Okay, right. That's good. No problem. So what are the plan? Or now that you intubated the patient, so what areas are you going to fix?
Parasymphysis
Yeah.
and subcondylar.
Okay. How will you approach the parasymphysis?
Through a lower gingival incision.
Yeah.
And we expose the after infiltration and after the incision, and we expose the fracture up to the lower border of the mandible. And after reduction, by seeing the continuity along the lower border of the mandible, we put two plates.
The contacts between the intracted. So
Where will the plates be situated?
One on the
plates.
one on the lower border and one on the upper borders.
Upper border. Which upper border? What are the problems? Upper border. Upper border, you got some other structure.
Root
of the teeth.
Root is
Yeah. Yeah. That's the champis line where you need to
Yes,
fix it.
along
Just below the
champis.
below the tooth buds. You should make sure that you are not injuring the tooth bud. Okay. Now that you have done it, so what will you do? Is it what kind of subcondylar fracture is it?
Low subcondylar.
Huh? Low subcondylar. That's
subcondylar.
good because it's going down below this thing. So this one is easier for you or difficult for you?
Difficult only. No.
Difficult only. Why? High subcondylar is much more difficult than this low subcondylar. Okay. On both. So how are you planning to? Why are you planning to fix it? Any other way it can be managed? Now that you reduced the parasymphysis nicely, and you got a good occlusion.
After
arch bars.
Yes, so we with arch bars, we will try to bring it into occlusion and put IMF loops.
If we are achieving
If we are achieving occlusion, then we can
we can yes.
Leave the subcondylar.
Why you may not fix it?
Yeah.
Because high risk of injury to the facial nerve, and it is involving only one side, not bilateral.
No, that's fine. I mean, looking at the type of the fracture, right? So even if you can approach there well and fix it, why would you not like to fix this and just go for IMF? Any other kind of fracture there you would like to fix? Any displacement? Angulation?
If it is medial displaced.
It is undisplaced. Medially displaced.
Yeah, it is almost undisplaced, right?
Yes,
so, and if you just maintain a good occlusion with IMF, it will heal in 4 weeks.
Yes.
How long will you maintain the IMF?
Rigid IMF.
If we are fixing the subcondylar fracture, we can switch over to the elastic.
No, without we are just talking about without IMF. If we are fixing, if I were the patient, I might opt. Why would you like to fix it? You tell me.
Yes.
Make the patient
early mobilization.
Yeah, that's good. Yes. Patient will not like to keep his mouth shut for 4 weeks. Okay.
Yes.
And it's better to start off early mobilization. What are the problems with the IMF for such a long time?
Ankles.
Oral hygiene, sir.
Oral hygiene, then
and then diet,
diet.
nutrition. And
Yeah.
in case if the patient has other associated injuries like rib fractures,
Yeah.
anytime he can
Yeah,
go
other
for
things. Okay.
respiratory.
Any other general contraindication? Okay. Then, like an unconscious patient.
And
for the same.
Yes, sir.
stiff TMJ.
So only thing we are after releasing, what are you going to have immediately? The bone would have united. What the patient will have problems?
Ankylosis,
Stiff
stiff
and
joint.
stiff.
Yeah,
TMJ.
stiff. The mouth opening is going to be stiff. It's not this thing. Trismus it's
Yes.
called. Okay. Ankylosis may
Trismus,
not
yeah, sir.
happen in such a low subcondylar fracture. Okay.
Yes.
But definitely all the structures around will be rigid and the patient will have difficulty in opening the mouth. Okay. For that reason, you might opt for fixing it. Okay.
Fixation.
If the patient decides and then you also patient desires and you also are competent, you can go ahead and fix it. So what approach will you do?
So
This is slow subcondylar, so we'll go for a retromandibular approach.
Okay. So what all you will cut and go?
As we will pterygomacetic fascia, and we will cut the pterygomacetic. Okay. Through the entire process, we have to see for nerve stimulation. For looking for marginal mandibular nerve on the cervical branch of the facial nerve. And once the pterygomacetic fascia is released, we have to go retroparotid and reach till the ramus. Once ramus, we have to elevate the tissues above the ramus and reach the fracture.
Okay.
And then we can fix it.
Yeah, that's a bit difficult when you go from below. Okay. We can still do it. Okay. We can still do it. Right. Because main problem is putting the angle of the screws. Okay. Any other method, they will advise people who don't want to have a scar, but you want to fix it.
transbuccal system.
Transbuccal system. How will you go? Endoscopic. Okay.
Yes.
Endoscopic, but that's going to be a bit difficult. It's not very common. I've seen few, but not very common. Reduction and then fixing it requires the side driving screwdrivers. Okay. Right.
Yes. And does.
Okay, so 1 more minute, sir. Sorry to interrupt. Next, we can move to the next session, sir.
One more question. How long will you this thing? What is the feeding advice once you release the IMF?
6 weeks liquid and semi-solid.
Okay, soft solid diet only. You
Soft solid,
patient should not think that he can start chewing normally. Okay.
Yes.
At 6 weeks it takes for some strength to come in. So soft solid slowly get converted to the hard. Okay. Right.
Yes.
Okay.
The rose ash and pulse forceps for nasal fracture fixing.
What ash?
Disinfection forceps.
No. Ash is not this thing, right? What is this? What do you see on the left and what is on the right side?
The left is a Rowe's disinfection forceps.
Rowe's disinfection forceps. And what is on the other right side?
So right side, thing like for palatal split, Hayton Williams.
Yeah. Okay.
Hayton Williams forceps.
Yeah. What is the difference between this and that?
So there is a screw stop for this Hayton Williams forceps, which can prevent the crushing of the tissues between when we are handling the palate, sir.
Okay. No, that's a right side. Left sided one is, as you said, a Rowe's disinfection forceps. Describe the parts. It is used in pairs. Okay.
Yes, the right sided and left sided is different.
Both. Yeah. You'll have to use it in pairs. Okay. Not as this thing. On the other hand, this is only one instrument system. Okay.
There are fan.
Yes.
So what are the parts you can see in that?
One on the skin surface and one on the mucosal surface.
I mean, one comes
external.
One comes exterior and one comes like interior.
Okay, I'll give you the clue that one is that curved portion where does it fit in? What is that curved portion meant for?
So
Have
that
you ever
comes
seen a maxillary this thing?
Yes, sir.
Disinfection? Okay.
Yes.
Yes, sir.
Why is that curved portion there?
To accommodate
Okay.
for the teeth.
Yeah, it is. It goes around the teeth. The flatter
Teeth, yes.
portion goes into the nasal
Intraoral, sir.
side. Okay.
Yes.
And
Yes.
the curved portion goes around this into that and holds
Yes.
on to the palate, maxilla. Okay.
Yes. Yes.
So you'll have to one for the left side, one for the right side, and
Yes.
do it.
Yes.
So how will you bring it forward?
By
Downward and forward.
Yeah, bit of a rocking movement. Okay.
Yes. Yes.
So that comes out. And after that,
Yes.
you go to the distance. So what is in this right side?
So it's an Hayton Williams forceps, which you generally used for these palatal split fractures, and
Yeah.
it has two. It's two blades, and there's a screw stop, which can control over the pressure which we are giving, sir.
Okay.
Yes.
So what are the types of maxillary fractures?
Yes, sir. The left foot 1, left foot 2, left foot 3 is there, sir.
Yeah.
Yes.
Can you tell what are this?
Left foot 1 is a transverse fracture, sir, which runs on the base of the nasal floor. And left foot 2 is like a pyramidal type of fracture, which runs from the root of the nose and inferior orbital rim and across the NM and zygomatic maxillary buttress. And left foot 3 is the craniofacial disjunction, sir, which runs from the zygomatic arch and crosses over the frontozygomatic and goes from the lateral wall and inferior wall and goes to the medially till the root of the nose and crosses.
Okay. So how will you fix a maxillary fracture? So now that there was a missing, what are the symptoms? Can see any of these things occur?
Yes.
The appearance.
We will have a malar prominence will be reduced on the involved side. Then
A flat face, a long face can occur. Okay. A flat
mid-face
face and a
projection
long.
will be lost. Yes. Yes.
Okay. That's
And
why
how
we are
you
doing.
how will you diagnose from the occlusion? What happens? How does a maxillary fracture occur? And
Yes.
how, because the moment you see the occlusion, you can make the diagnosis of
Yes.
of a condylar fracture, of a maxillary fracture.
Yes, sir.
crossbite.
Crossbite will be there, sir.
What in a maxillary fracture?
Yeah. Yes, sir.
No.
Obviously.
How does the maxilla telescope? So see, how are you disimpacting the forward and downward? So it is going. You understand, upward and backward.
Yes, sir.
Yes, sir.
So that what is it called? It is called as the anterior open bite.
Anterior open.
And you know, okay, so a cross bite will happen in a mandibular fracture.
Yes.
If it is a condyle, but in a maxillary fracture, it will be an anterior open bite. Means there is a posterior occlusion, and this Clayton forceps is used when there is a palatal disimpaction and
Splitters.
the posterior occlusion is not achieved. So you have to compress the maxilla from
both
that
sides.
is the time when you use this forceps.
Yes.
How will you fix the maxillary fracture?
From top to bottom and from outward to
Only
inward.
maxilla I'm talking. Okay, right. Okay, right. Again.
Yes.
Have you seen one being done?
Yes.
Yes, sir.
Okay, right.
Yes.
Like mandible only. What did you do? Trying to do?
Along the buttress lines, arch bars.
Okay.
As usual, we'll apply the arch bar, sir. We'll get into occlusion and yes.
And then expose the fractures.
Give the gingivobuccal incision, whichever side is involved, sir, after infiltration, and expose the fracture side and bring into the reduction and see for the occlusion whether we have achieved the normal occlusion. and fix it with the plates, which where these two holes is come on the either side of the fracture site. And yes, sir. And fix it.
Yeah, she mentioned what is the buttress?
Yes, sir.
Horizontal buttress and vertical buttress. Here along the maxillary and mandibular arches, horizontal and inferior orbital rim and
Why do
superior
you choose
orbital
that?
rim.
Why do you want to choose that?
These are the stable, like thicker part of the
Those are the thicker
bones.
parts. You cannot, if you look into the maxilla, you'll see that. What is it filled with?
Yes.
It's a maxillary sinus, right?
What, sir?
Corticocancellous.
Yes, others is filled with
Maxillary
air cells.
sinus. You cannot
like
put the
buttress or
plate anywhere you like. Okay. It's filled with the maxillary sinus. Only the lateral most and the medial most part are the solid bones. Okay. That's what is the buttress, where you will have to put it. Otherwise, maxillary antral wall is something like an eggshell. You cannot be fixing it. Right.
And screw will float.
Yes.
Yes.
Anything else? Dr. Mahesh, Subodh?
I think they have answered well most of the questions.
Can I move to the next
topics?
Yes.
Let's go ahead.
Male patient.
The male
bilateral kind of
Male patient. No.
bilateral grade 3.
It's a bilateral grade 3 gynecomastia according to the Simon's classification. We will counsel the patient regarding the investigations needed to rule out for the cause, whether there is an endocrine cause or not, and we will tell him about the procedure which we are going to offer him. Like since it is like grade 3 gynecomastia, we can go for the liposuction along with the Webster procedure. We can do.
And for the skin redundancy, post-operatively, he should be on compression garments for 6 months. And to avoid the weight gain.
Okay.
So after the liposuction, what will you do with the remaining glands? What incision you will do?
Perioral incision starting from 3 to 9 o'clock positions.
Okay. What will you do with the redundant skin?
We can do a banally kind of excision.
And when will you do that?
What's that?
Perioral.
So tell me your operative procedure. What procedure you are actually going to do in this case?
So liposuction along with the Webster procedures.
Liposuction along with the
Webster's
procedures.
May I?
Yeah.
Is it Webster's procedure or is it Webster's incision? Webster's, you said?
Yes, sir.
Yes, sir.
Webster's incision or Webster's procedure?
Webster's procedures.
No. That is Webster's incision. 3 to 9 is Webster's incision. Right?
Yes.
Yeah. She rightly told perioral excision for the loosely hanging skin. That is Benelli also she mentioned. That is right. But there are certain criteria for how much you can expect to condense towards the center, towards the nipple, how much skin. There is a calculation. Do you know
Yes.
that? Tell me.
So, 2 centimeter on either side, or you?
No. Okay. I think it is not given in the regular textbooks. Shall I?
Yes. Yes.
That is first. Okay. Tell me how much areolar size you decide first. You aim it. You target.
Yes, sir. 1.5 to 2 centimeter on either side of the nipple, sir.
No.
That I-
No. How much you are going to retain? I am asking.
Retaining of
Nipple size, areolar
NAC,
size.
yes, sir.
2.5
Not
centimeters.
NAC, areolar size.
2.5 to 3 centimeters, sir.
No. Okay, you are not getting my point.
Yes.
In this patient, areolar size is okay, acceptable, because when it
Yes.
when the weight of the breast gland or fat is removed, it will contract
Yes.
and it is okay. So
Yes.
the limitation, you read Bernoulli's original article again, the limitation is, it is twice the size of the expected areolar size, areolar diameter. If
Yes.
the areolar diameter is 4.4 centimeters total,
Yes. Okay.
your limitation is double the
Okay.
diameter of the circle, right?
Someone.
And also periareolar and circumareolar, they are different. The terminologies are different. Circumareolar is all round.
Yes.
Periareolar is your Webster.
Yes.
Okay. So this diameter is okay. You measure this diameter. Did you measure?
Yes.
I don't think so.
Sir, we didn't see the patient, sir.
Okay, fine.
Yes.
I'm giving you the principle. So
Yes.
this
Yes.
diameter, if it is 5 centimeters, accept it. So
Yes.
your final diameter is going to be 10 centimeters, and through the Webster's incision, you will enter the gland inside into the breast. And skin excision is by Benelli with
Yes.
the calculation I am telling.
Concentric. Yes.
Yeah.
Yes.
So first you will do concentric deepithelialization, or you will
And
remove the gland first. Which will you do?
concentric deepithelialization after the removal of the gland, sir.
No way. That is why I asked the question. Once you remove the gland, you will not
Yes.
get the hold.
Yes.
The gland will be loose, and you cannot stabilize it easily. So
Yes.
first you excise periareolar skin deepithelialization, then make an incision, your Webster incision or whatever you
Yes.
choose, make an incision, go
Yes.
into the inside, do anything what
Yes.
you want.
Yes.
Usually it requires some sort of excision. You have to go inside. If you do liposuction alone, and especially at your stage, you are not
Yes.
going to remove the complete gland, and then the patient will not leave you.
Yes.
And the first opportunity is the best opportunity.
Yes.
So you do the deepithelialization, make the incision, enter the gland, whatever you want to excise, you want to identify the gland, excise it, and do the liposuction to the lateral axillary folds and to the surrounding chest area. Then do the Benelli closure.
Yes.
After closing Webster's incision.
Yes.
Then do the Benelli closure. And once the tissue is removed, the weight is removed, it will retract back, and then you are going to give the compression garment with or without using drains. Using drains is your optional. You have option.
Yes.
So after closure, you give the compression garment, and then how long you want to give compression garment?
The minimum of 6 months, sir.
Exactly, I like it, because there is a controversy. Some people say 3 weeks, some people say 3 months. 6 months is required because it is not just the skin, the whole area, surrounding area, the whole thing has to heal. And this is, as you said, it is grade 3.
Yes.
Right? Or type 3 Simons.
Yes.
So it will retract. So, but
Yes.
it takes time. Till then, you do the compression garment. If there is any problem, like Indian atmosphere or summer or it like that, you give during the, make the patient free. After 3 months, make the patient free to use it for during daytime.
Yes.
And then patient will use it in the night time.
Night time, yes.
Okay, that is
Yes,
how
sir.
you do that. Okay, doctors. Sorry, I took long time. Please go ahead.
Sir, I think we have reached the time
I know.
of 10 minutes. Can I move to the next topic, sir?
Please do.
Right.
Go ahead.
Okay.
Documentation. And that's possible.
Sir, can you zoom the picture?
This is a soft tissue.
Yes. Injury. Okay.
Probably post-traumatic injury with a soft tissue defect on the anterior upper third of the right leg and an abrasion injury on the medial aspect of the
Recording in progress.
of the medial aspect of the knee. Soft tissue defect involves the skin, subcutaneous tissue, and with the bony injury. Probably.
There's no fracture.
Yes.
I'm giving you the information. There is no fracture.
Yes, ma'am. Yes, ma'am.
Yes. We would like to document all the injuries, ma'am, and if it is like the nature of injury, whether it need of the MLC is there, medical legal filing we will do, and we'll document all the injury types and what did we counsel the patient, and we will explain about the procedure what we are going to do, and we will see for pulse, and if there is any need, we will go for the CT angio if needed, ma'am, and
CT angio?
If needed, so if the peripheral pulses are not.
Why do you think you may need a CT angio in this case? Because
yes,
where do the vascular structures travel along?
There is
So
one.
before that, what will you document? Okay, before that, what will you document?
The sensory motor examination.
Yeah, just clinically. Okay, right.
And
so what do you think?
range
What
of
are the
movements.
problems that patient can have?
Dorsiflexion.
Yeah. Okay. In the lateral view, you can see something, maybe just a postural. The patient is still, the foot is plantar flexed, but you can still see the tendon prominence in the EH area. Okay. First thing you'll have to document is because it's, you can see some part of gap is there in the bone, but Madam Lakshmi told that there is no fracture. But adjacent to that, it's what compartment is there? What muscle compartment is there adjacent to the injury or directly under the injury?
Anterior compartment, sir.
Anterior compartment. So if it gets damaged, what are the things you'd like to see? Because all the muscles are getting originated there. We don't know the extent of injury just by looking at it. What will you like to document?
Extension of the toes, ankle dorsiflexion.
Yeah. So individually, you'll have to check for the extensor hallucis longus, extensor digitorum longus, and tibialis anterior.
Tibialis anterior, yes.
Yeah. All those things you should individually listen. Then
nerve examination. So,
Sensation over the first web space.
Yeah. Okay. But that is given by?
Deep pheromone.
DPMs.
Okay. Right. So those are the things you'll have to document it because the injury is anterior. Make sure that always always you are telling about MLC problem. One is movements you'll have to document. Sensation you'll have to document. And third?
Pulses.
Pulses. Okay. Neurovascular exam clinical. Always you have to put your hand before asking for a CT angio. Have to put your hand on the pulses. What are the pulses you'll palpate?
ATA, dorsalis pedis and PTSA.
ATA you cannot palpate as such. Dorsalis pedis you are palpating, right? And the posterior tibial artery. Okay. Always use the full names. Okay. ATA. Okay. Anterior tibial artery or dorsalis pedis and the posterior tibial pulses you are palpable. But even if the anterior tibial is injured above, you can still get a anterior tibial artery, dorsalis pedis artery pulsation. So how will you check out on it?
By an Allen's test on the leg.
Okay. What will you do? Allen's test, how do you do?
Compress
Sir.
Yes.
I mean, the trainees, don't use abbreviations in your examination.
Yes.
I always tell that suppose you tell TA, it can mean tendoachilles also. You can say people use it for tendoachilles, people use it for tibialis anterior. So never use the abbreviations. Okay.
Yes, sure.
We occlude both the anterior tibial artery and the posterior tibial artery.
Okay.
And release either one.
And see for the pulsation whether it is disappearing or not.
Oh, not really. Okay, right. In the hand, how will you do? Before the occluding both the pulses, what do you do?
We ask the patient to open and close it, make a fist continuously.
Yeah, that's why at least you have to empty it fully. Okay.
Yes.
That's what you are looking at. Okay. Not this thing. Okay. Basically, you just look at it, the capillary refill after releasing one and after releasing the other, and see how it fills up. Okay. If the anterior tibial is you occluded, first you exsanguinate the foot. Okay. Just by a compression, and occlude both the arteries. If you release anterior tibial artery is injured, once you release the anterior tibial artery, still holding the posterior tibial artery, compressing it, you will not get a filling, right?
Yes.
Okay, right. What else will you like to have an X-ray?
Yes,
sir, sure. So to rule out the fracture.
Madam said no fracture, but why do you still like to have an X-ray? Tell me.
It is a deep soft tissue defect and for medical legal purposes.
Still in the profile, I might have still a unicortical loss. Okay.
Yes.
You may not treat it, but still it may have a unicortical loss or indentation, which is required.
As well as retained foreign bodies.
Yes.
Yes.
I will get a cough syrup for myself. I will get a cough syrup.
Then what else will you document?
Any other injuries in the body?
Okay, right. Anyway, compared to this proximal joint also, you'll just document the movements just for the completion sake of it. Proximal joint also, you'll have to check the movements. It's always because Dr. Venkatratnam, what he tell was correct. Foreign bodies missing it. Okay. Even otherwise, you should always make sure that when such a other thing, some sand, gravel, everything can be seen. So you can just take it off.
Can ask cooperative options also, sir.
Okay, right. That okay. I'm thinking only
they
like
have to
limit in the
document that also.
documentation. Okay.
If they have
What?
to fill that also, have the counseling and
Okay.
video consent.
Okay.
Also for documentations only, which are very important for me, medical legal.
We have to counsel the patient regarding the soft tissue loss and the loss of
Okay.
periosteum.
Yeah.
And if the need for cover.
Soft tissue.
So we like to proceed with the local regional by putting a gas drop flap.
Yeah. How will you raise a gastrocnemius flap?
Incision can be
Midline incision in the calf.
Okay.
And, find the plane between the medial and the lateral gastrocnemius muscles.
Okay.
And find the plane between the medial gastroc and the soleus by identifying the plantar tendon.
Yeah.
Going to the tendinous part and dissecting the tendinous part 1 centimeter beyond the musculotendinous junction.
Okay.
And,
Why do you need that tendinous part?
What's that?
Why do you need that tendinous part? You are retaining a bit of cuff of tendon.
Yes.
Why do you need it?
For the anchorage to the
Suturing.
Okay.
Suturing will be better.
Right. Then
and then elevate from
what are the
distal
structures in the midline you need to be careful about before you approach
Sural.
the gastrocnemius? Sural nerve. Then what runs along the sural nerve? Along with the sural nerve. Short saphenous vein. Okay.
I think they lost the connection. They are.
All right.
Hello, sir.
Are you there?
Sir?
Yeah,
They
go ahead.
joined back, sir.
Hello.
They joined back.
Okay.
Go ahead.
In midline, there is a sural nerve and vessels will be there.
Huh?
Hello.
Sir?
Are you back?
Yes, sir.
Yes, sir.
Divya Lakshmi. Are you back?
Yes, sir.
Yes, sir. Back.
Okay.
Yes, sir. Yes, sir.
Okay, you can proceed.
Sir, when we encounter the sural nerve and the short saphenous vein.
Yeah.
Medially, we will encounter the great saphenous vein and the
Great
saphenous
saphenous
nerve.
vein medially. Okay, right. Because you are doing a midline, you are going under the fascia straight. Okay. Midline incision only, you will see all the structures. Okay. After that, you are going under the fascia. Okay. You may not see the great saphenous vein. Okay. You have cut this thing, and how will you bring it to the anterior portion?
We can either go through a subcutaneous tunnel or we can lay it open and bring it anteriorly.
Okay, right. What will you prefer?
Prefer a subcutaneous tunnel.
Okay, right.
The question is what you will do.
Okay, you just see that, okay, it is falling 1 centimeter short or 2 centimeters short. Okay. Which belly are you taking? Medial or the lateral belly?
Medial.
Okay, right. So you feel that, okay, maybe 1 centimeter short. Is there any way you can extend the reach of the gastrocnemius?
We can go proximally up towards origin and
distance at the origin.
Okay.
From the
Yes.
At the tendinous origin, you can cut on the superficial surface. Okay. That will because the muscular pedicle is coming from deeper side. Then what else can you do? Anything else?
Visiting till the pedicle, sir.
That's okay. Then anything else?
Scoring.
What is in the undersurface? Yeah. The upper neurotic scoring you can do. Okay.
Yes.
Bring it forward and do the.
Yes.
But I think time.
Okay.
You tell other options. Can you tell any other options? Just name them.
Fasciocutaneous flap. You can.
Okay.
Free flap.
Free flap. Final option can be the free flap.
Fine. Before closing, you have three options now. You will directly choose, or you will give option to the patient.
What, sir?
You will give option to the patient. You will tell all the three flaps, and
Yes.
then involve the patient in the decision making, or you will take the decision.
Yeah, we'll involve the patient to take a decision, sir.
So this being documentation, why I asked that question is, you have to mention, we have to document, you have to give, we have given all the three options, and the patient has chosen this particular option, and then get the patient signed. Right,
Yes.
go ahead. Over
So
to you,
you
sir.
have to explain the pros and cons of every procedure.
Each of the flaps,
and
each
give
of the
the
this thing.
of each flap, and you should tell the patient to choose.
Yes, sir.
Yes.
Yes.
Now we'll go to the questioning session. The other teams should put questions to the presenting team.
And now I
Rohit,
call
Leonard.
team one from Madras Medical College.
Good evening, ma'am.
Yeah,
My question is, what are the various intraoral sites available for bone grafting in case of alveolar bone grafting?
Yeah. There are three sites available. We can do maxillary tuberosity, we can take, and symphysis mandible, and the retromolar region we can.
Yeah, okay.
Now question from team two, Jipmer Pondicherry.
Yes, sir. What are the indications for the alveolar bone grafting?
Yeah, alveolar bone grafting, which can be done for the eruption of the teeth, and the nasal floor. We are giving a base, and we are giving the alveolar arch alignment, and we will prevent this fistula. Alveolar fistula we can prevent.
And when the gap between the arcs is more than 2 centimeters.
Yes.
Okay.
Thank you.
Can we move to third team from KGMC Lucknow? PGs from KGMC Lucknow. PGs from KGMC Lucknow. Now move to team four from Stanley Medical College.
Good evening. My question to you is, what are the causes of vermilion notching?
What?
What are the causes for vermilion notching?
Wait, I think they have very unstable connection.
They lost the connection.
Yes, ma'am. It seems like that.
Yeah.
Hello, can you hear me? Hello.
Yes.
Hello.
Yeah,
Prashant, we
what's
can
the
hear you.
question?
Yeah, ma'am. Vermilion notching, this inadequate rotation of the rotation flap, and this deficiency of the vermilion thing which you are not addressing. Which can be addressed by triangle of the vermilion tissue from the lateral segment, which can be given to the medial segment, which is explained by the Dr. Rajesh Power technique that can be done. And this inadequate muscle dissection also can cause a vermilion notch.
Okay, so my second question is, how will you suture the white roll?
White roll, we should not put a suture across the white roll. One above the white roll and one below the white roll will be appropriate to prevent the white roll scarring.
Okay, thank you.
Prashant, I request you to switch off the video because
Video.
Your network is very slow. Okay. Now I request
If two gadgets are working at the same time in the same room, all these problems will arise.
I think
So
both are
switch to the
using-
second one.
Okay.
Like here, not that way.
Prashant, it's not clear. Okay, fine. Now, team 5, AIMS New Delhi. PGs from AIMS New Delhi.
My question is, please define incomplete cleft lip and its types.
Incomplete cleft
Prashant, 1 minute.
Audio
1
is
minute.
not.
Your audio is not at all clear. You better disconnect and connect once again.
Yeah, one.
Rohit,
Sir.
many people have put their name as iPad, iPhone. Please see that they put their original names. Okay. If they are online, let them go take over.
They might be listening, so we'll ask them to do that.
Hello.
Yeah.
They
Hello.
log in. Prashant,
Yes, sir.
that you?
Yes.
Yeah, yes.
Okay, just okay, right now, fine. You heard the question, right? From
What question? The last
Nandini.
question was, I don't remember, sir. What last
Define
question?
incomplete cleft palate and what are the types?
Is it palate or lip?
Sorry,
Lip.
lip, sorry.
When the entire lip element is not involved in the cleft and nasal floor is intact, for the nasal cylinder is intact, it is an incomplete cleft lip. It can be
It can be divided into 3 forms: mini form and micro form, and mini micro form is there.
many forms.
Fine. I mean, there are certain specific that measurements for that, right?
Yeah.
When we call it minor, when we call it.
Yeah.
Mini when there
When less than 3 mm.
centimeters above the white roll is involved, it is mini. Micro up to 3 millimeters, and mini micro is when there is only a notching with an intact white roll.
I'll just give the definition for you. It's a variable degree of separation in the lip with an intact nasal sill or a seminoid band. Is incomplete.
Yeah.
And as you said, that microform, which is also known as forme fruste, is less than 3 mm, and the
Yeah.
microform will be like greater than 3 mm.
Yeah.
Okay, fine. I will ask next team 6, Bangalore Medical College.
Good evening, ma'am. This is from Bangalore Medical College. Is I am audible?
Yes.
You're audible,
Yeah.
you're audible.
What is the Bangalore classification of craniofacial and cervical cleft?
What?
Bangalore classification of craniofacial clefts. I think.
Bangalore does no. We don't.
And we don't
know.
Okay. The commonly used is that is Serpau's Tishier's classification. In
What?
Tischer classification, commonly we are using Tischer's classification. In Tischer's classification, he is doing a cleft around the orbit. He will make a center as a orbit for the classifying the clefts. In which in Bangalore classification, it is classified by Dr. S.A. Subramani, in which he centered the oral cavity as a center. So around the oral cavity, so 0 to 14 clefts will be there. So this is called Bangalore classification.
So it's like Tessier only, you're saying?
Yeah. So in Tischer, around the orbit, in which
It's like a
in
bony. This is also classified as a
both
soft tissue and bony. Yeah.
soft tissue and
And bony. Okay.
skeletal bone.
Sure.
Now I would like to ask questions from anyone to question from team 8, Safdarjung Hospital, New Delhi.
Good evening. Can you tell me about the Stephenson's criteria?
Stephenson's criteria.
Hello?
Yes,
Stephenson.
criteria.
Yes. Stephenson's criteria and what are the components?
It has 5 components for accurate approximation of the vermilion skin and the nasal cell, and symmetrical approximation of the nasal cell, symmetrical approximation of the vermilion.
Horizontal cupid bow and symmetrical nasal floor and symmetrical vermilion height we have to, and there should be a approximation of skin, muscle and mucosa, and the scar contracture should not be there, and it is like a Musgrave as given to where there should be a symmetrical nasal floor should also be there. Cupid bow.
Yeah, so basically 2 criteria were added later on by Musgrave, which was preservation of preservation of Cupid's bow
and symmetrical nasal floor.
nostrils.
Nostril.
Because nasal floor had already been described by Stephenson.
Sure, nostril, yes.
Okay. Yes, thank you so much.
Thank you.
Next, questions from team 9, RML.
Hi, am I audible?
Yeah.
Hi, good evening. I just wanted to ask if you could elucidate the goals of a LATAM's pre-surgical infant orthodontic splint. There are 3 goals. I'll repeat the question. Can you elucidate the...
LATAM's is a PSIO, like a pre-surgical infant orthopedics, which they have given. Like the
Can
goals,
you elucidate the goals?
The goal is to align this alveolar arch, which is mal-aligned, and it should be started as early as possible, and the maximum effort we cannot get after the period of the 6 months, and you should start from the 3 weeks itself. And it's a weekly adjustment which you have to give this palatal acrylic splint, and
Prashant.
Yes.
The question is, he's asking what are the 3 goals?
Goals is
what
to
you are
align
going to achieve using a LATAM's device.
Targets.
Alveolar arch can be aligned, and
one is arch get aligned, one
Lip adhesion and nostril adhesion.
the nasal deformity reduction.
Cell reduction.
Can you explain that a little better what exactly does it correct in the nasal deformity?
That alar buckling and alar flare.
Columnar lengthening.
No. I'm quoting from the article by Latham himself, as mentioned in McCarthy's. So basically, the overall effect that is expected is the reduction of the width of the cleft. And as you mentioned, it improves the alveolar segment alignment. But it also corrects the depression of the cleft alar base. Additionally, can I ask you if you know what is to be done after the application of the splint? Is there any other procedure that has been described by Latham? If you know, maybe.
Like weekly
Lip adhesion.
Lip adhesion we have to do like that. Poplar.
Not lip per se. If you know or not, I'll explain it if you don't. But
no, are you asking about poplar?
No. The original description by Latham mentions the performance of a gingival periosteoplasty 7 to 10 days after the achievement of, after the application of the the splint.
And I think this poplar is also like pre-surgical orthopedics and periosteoplasty lip adhesion. That is also comes as a
So I'm talking about the gingival periosteoplasty actually mentioned by Latham himself.
Sure.
Thank you.
Then. Thank you.
Next question from Kilpock Medical College, team number 11. Team 11, Kilpock.
Good evening. This is Dr. Sai Karthik from Kilpock Medical College. And especially in cleft lip or cleft lip and palate associated, you take throat swab. Why is it taken and what is the significance?
Mostly it is indicated after 3 years to see for streptococcal infection, and because post-op hemorrhage, reactionary hemorrhage is more because of the inflammation, and the suture giveaway is more.
Yeah, correct. I agree. Just one point to add. It also lyses the vital sutures. So that is one of the reason for suture giveaway. Yeah. Thank you. Yeah.
Thank you.
Thank you. Next, team 12, MAMC New Delhi. PGs from MAMC New Delhi.
Hello.
Hello, yes.
Yeah, can you enumerate the syndromic cleft names?
Yeah, Van der Wood syndrome is there, and catch 22 deletion syndrome is there, and Stickler, Fear Robin, Stickler, and
D. George. Uppert, Down syndrome, Treacher Collin.
And my second question is, what is palatal index?
What is?
Palatal index.
Palatal index.
It is
The cleft.
Rosenthal and Perry, but it is the cleft width divided by the addition of the right and the left palatal shift. It is divided into 3 grades. 0.2 is mild, 0.2 to 0.4 is
Moderate, and 0.4 more than 0.4 is severe.
Yes,
for palatal fistula.
Okay, next. Next, I would like to ask questions from team 15, AIMS Bhubaneswar. Do we have anyone from AIMS Bhubaneswar, PGs?
Good evening. I'm from AIMS Bhubaneswar. My question is, am I audible?
Yes.
Yeah. My question would be, could you please explain what a submucous cleft palate is and what is a classical triad associated with it?
Submucosal cleft palate is one in which the mucosa, that is oral and nasal mucosa is intact, but only the muscle alignment is improper, wherein like there is the levator palati, they do not form the proper sling, and they pose on a vertical orientation and attach at the posterior edge of the hard palate. The triad is the Kaplan's triad, wherein there is the posterior hard palate notching, zona pellucida, wherein the bifidula.
Hello.
Done.
Okay.
Next.
Next, team 16, AIMS Rishikesh. PGs from AIMS Rishikesh.
Hello, good evening. My question is, can you describe the embryogenesis of cleft lip?
Embryogenesis is from the frontonasal process down. It all centers around the somatarium, and the frontonasal process divides into the medial nasal process and the lateral nasal process. And from either side, the maxillary process comes and attaches to the median nasal process. If this is hindered, it leads to cleft lip and to the cleft of the primary lip and palate. And when both the horizontal plates of the maxillary process do not attach to the midline, it causes cleft of the secondary palate.
Okay, fine. Thank you.
Thank you.
There is a message from team 3. Right now, are you there in the discussion?
Yes, sir.
You can ask the question now.
My question is, Nagpur classification is a modification of which classification? It is a modified one.
C. Balakrishnan.
Yes, yes. It's a modification of which?
What are you asking?
Nagpur classification is a modification of.
It's based on which classification, not a modification. Is based on which classification? That's the question to be appropriate.
Dr. Balakrishnan.
Anatomical classification like that, you were asking anatomical or embryological, like not getting your thing.
Not, there are a few more classifications like
VU, you're saying VU classification?
Yeah.
VU, okay.
Those lines.
Yeah.
Vichy Davis.
Hello.
Karthikla, you are there?
Yes, sir.
Yes, sir.
I mean, asking for the guy
Three.
from. I think
Team
Rishi,
three.
team 3, KGMC
Hello.
Lucknow.
Yes, sir.
You want to say it is based on Richie Davis?
Yes, yes.
Yes, that is the answer, right? Yeah, fine.
Yes.
It is
Done.
based on Richie Davis classification.
Oh,
Richie Davis.
And now I would like to ask the team, newly added team, Nizams. Do you have pages from Nizams? I think, do we have pages from Nizams? Vishal or Sandeep? Anyone? It's okay. Okay, ma'am, we are done with this session.
What
Now,
about team 7 and 10?
sir, actually,
we are team
Sir,
7.
two teams, they actually first years they have given the names, so they withdrew from the competition.
So 7 and 10 is not there.
no,
Sir,
sir.
7. We are team 7, sir. Presenting team
Right
is team
now,
7.
7, sir.
Presenting from?
13, I
Achha,
think.
right, okay.
13.
Right now, team 10, team
10.
and team 12, team 13, sir. Team 13 and team 14. They withdraw from the competition, sir.
Okay.
And NIMS joined in place of 13.
Okay.
But they are not present.
Not present today, sir.
So 10 is also not there. They have withdrawn.
Yes, sir. BJMC Pune is not there. ESIC Faridabad and SRMC Chennai. These 3 teams withdraw from the competition. Withdrew from the competition.
Now, Rohit, clearly tell who are absent, who withdraw.
NIMS is absent, ma'am.
Yeah.
And team
NIMS is number 10.
13, sir. 13.
13. Okay.
Newly added 13, sir.
Hmm.
BJMC Pune, previous team 10. And
10.
team 13 ESI Faridabad. And team 14 SRMC Chennai. These 3 teams withdraw from the competition, sir.
So now at present only 14 teams are there for
14
competition total. So today we are finishing 7th. So this will become the first group. From next session onwards will become second group. So one team will be selected from these 7 teams for the final. So
Right.
that will be decided by the team of judges.
Right.
Okay.
Madam Rohit, can you tell the new teams which have been finalized because some have withdrawn? Can you tell me the new teams?
Only one team.
Only one team.
Joined, sir. We will share the table again to all the judges.
You just share in the judges.
We will share to the judges the new teams.
Giving the
So,
number and name.
Yeah,
Okay.
yeah, yes, sir. Yes, sir. First 7 we have finished. So one group is completed today, and
Job done.
yeah, from tomorrow onwards, the next group will start.
Okay, fine.
Dr.
Now,
Lakshmi,
yeah, sir.
I mean, this iPad, iPhone, this display, names display, we don't know in between while the session is going on, some nonsense, some nuisance, some extra sounds, disturbing sounds and all. We don't know. We cannot call iPhone. We cannot call this phone. So please make them put one name at least.
Actually, we can request them that they put proper names there.
Exactly.
Yes, sir.
Yeah.
We'll
It is
give
better if everybody identifies himself or herself.
And
We are
another thing
part of
is,
same community. It is better we identify ourselves. That is better.
it is better that the presenter should have in the laptop rather than in from any phones. The presenter who is presenting.
Okay, as
Yes.
it is already announced, everybody know from next time onwards will expect that they will keep the names.
Sure.
And
Whoever,
better that
participated. And now I request the panelists to give their opinion about today's pages presentation and any suggestions.
Lakshmi,
Sir.
they have to please instruct them maybe on personal messages. Please instruct them.
That
to
is very
use-
difficult
One
to
second.
who are presenting, and groups we will put in all groups.
No problem. No problem. That's not my point.
Send the message.
No. My point is only one gadget, one laptop or one desktop is
At a time.
At a time. No,
Yes.
no phones, etc. Should be there because they are giving disturbances. Please go ahead.
Okay, sir. So, Rohit, you please invite the panelists. I think I request Dr. Subodh sir.
Yeah, I think the
Rohit.
presentations, the presentations were really good and they described everything in detail, but they have to be a little more systematic. And when they're describing the deformity, they have to elaborate every anatomical structure. So the idea of assessing the deformity is to know the deformity so that you can plan the reconstruction or repair. And they described the cleft lip deformity very well. And as this was a complete case, they should have described everything right from the nasal bridge to nasal dorsum, supratape region, columella, the base of the columella, base of the ala, and lip, and especially the philtrum. The philtral part they did not describe in great details, because philtrum is the key to repair any cleft lip, and you need to make it symmetrical. They knew everything. Later on, they mentioned everything, but they did not describe it primarily. So we were all focusing on the philtrum and the disparity in the two sides of the philtral ridges, and also on the thickness of the vermilion. And they knew all this, but they described it in piecemeals when asked. So, and as far as the planning and performance of surgery was concerned, I mean, they could choose any surgery which is commonly performed in the department where they are working. So any lip can be repaired by any kind of procedure. And most of the surgeons do make some modifications in the basic surgical techniques, like even if it's Millards or triangular flaps. So everybody makes a little bit of changes in it. So they can learn it from their department and describe what is being done. But they should describe it in detail. And because at this level, they are supposed to perform those surgeries. So they should describe the dissection very well, going into the details of, for example, when they are dissecting the muscle, they should express till what are the planes, what are the distances, what are the depths, where will they separate it from, and how will they repair it. So they did all that, they mentioned all that, and they knew everything. And but maybe there were a lot of interruptions from the faculty, or they were not able to describe it in a flow. And it may be that all the faculty wanted to hear something what they wanted to hear, and their flow was obstructed. But overall, their performance was extremely good. And in the cases later, on the spots and other cases, and especially in TM joint, and again there, they knew everything, and but there were a little hesitations in describing those things in a first go. But when asked, they could answer everything. And similarly, in the leg defect as well, they described almost everything, and they gave their first option, which was fine. And when asked, they gave this other options too. They also handled the questions raised by the faculty as well as the other teams. And overall, their standards of knowledge and information was very high. And about the Plastiquest, I think this is a unique platform. And I wish we had when we were the residents. And this brings all the residents and faculty together at this platform. And this is very informative, and everybody is learning something from it. Not only the resident, but also the consultants who are attending this, they're learning from it. This is a This is giving a completeness to their training. This is complementing the training that they're having in their department. So I have all the praises for this initiative, and this is working very well. And I would like to thank the organizers of Plastiquest for doing this for our PGs and for our faculties. Thank you so much.
Dr. Subodh, sir.
Yes.
One caveat is, after the Plastiquest is over, please continue to be associated with Plastiquest. Please share your knowledge.
I was about to request, please continue to send me the links, and I will be very happy.
We are
It will be done.
all the links, even APSI groups, your community and South Zone, Burns, Nabicon. Sir, I'm circulating 3-4 times. I'm sharing, sir. Really, I'm spending
I know.
1 hour
I know.
for sharing.
I promise that I will continue to attend this. And see and since you gave me another chance, let me speak for a couple of more minutes. So as far as the cleft is concerned, so I would like to say this to all the PGs, that you should not focus on learning a technique. You should focus on learning the concept of cleft. So what is the actual deformity there? So understand a deformity, which is different in different patients. So understand a deformity and how that deformity should be corrected. So the techniques are simple and you will learn in some time, but concept you have to understand very well. You may be involved in just learning, which is the point number 1, 2, 3, 4, 15, right? But that's not the way to learn cleft. You need to understand the concept of the cleft, the deformities of the cleft, right? And where will you put those points? You can put them 1, 2, 3, you can put them A, B, C, X, Y, Z, whatever, right? But you should know what are those points and why you are putting those points there. So what are you trying to achieve? And also there is a lot to understand in the cleft, right from its causation to its treatment. Right, so we do not know for sure why cleft occurs. There are more than 350 genes which are associated with this. There are a lot of nutritional factors which are associated with this. And even in embryology, we need to develop our understanding. Right, I mean, there are so many ways it has been described. So the lip comes from the primary palate. So you can say the complete cleft of the lip is only when it reaches up to the incisive foramen. And complete cleft of the palate is when it reaches from the uvula to the incisive foramen. And somehow the incisive foramen is the jipping point. From there, if you go anteriorly, the lip is jipped. If you go posteriorly, the palate is jipped. You will never find a cleft where hard palate is cleft and a soft palate is not cleft. You will never find a cleft where alveolus is cleft, but the rest of the lip is not cleft. So the jipping starts at the incisive foramen and goes up and down, right? So, and if you think that way, you will be able to describe every cleft deformity. You will be able to understand every cleft deformity. And coming to the Simonot's band, right? It is difficult to describe the Simonot's band. Different people will describe it differently, right? Starting from Millard's, they will describe it differently, right? So some people will say it is a bridge. When you find a connection below it, it is a Simonot's band. Some people will say it is just a connection, right? So which is described as Simonot's band. But what is Simonot's band? I mean, nobody knows. I just found one article which mentioned, which is a very detailed article, that the closest that it came was to Dr. Simon. So, or Simon Arts of Germany. Arts is for doctor. So he was in 1862 to 1868, he published these findings in some of the groups where he was using a flap for bilateral lips to bridge that gap. And that flap was called Simon-Arts band. Now it changed to Simon-Arts or Simon-Arts band in the later year. So even Millard described it, right? So, but it has been searched in an article published in 1973. It has been very well described, right? So But that doesn't give you anything, right? Whether it is an incomplete or complete. A complete cleft of the lip is when right from the vermilion up to the incisive foramen, there is a cleft. The primary palate is cleft. The lip is a part of primary palate. When you mention lip and alveolus separately, embryonically, they are not. So they are part of the primary palate. Right, so the complete cleft is when it is up to the incisive foramen. Rest all is incomplete. Now there can be degrees of incompleteness which different people can describe. Similarly, the soft palate as well. And when the submucous cleft was mentioned, there's also an enigma. So many submucous cleft which appears real submucous short, and the patients may have absolutely normal speech, and in other where just partial uvula cleft, and the patient may have a very nasalized speech and velopharyngeal incompetence. So there is a lot to understand and learn, and as everybody says, no two clefts are same. So therefore, you have to understand and you have to develop an understanding of the